I couldn't look at it. I will see you.
Yeah, we can see. We can see the slide.
Hello. Can you hear me? Good afternoon, guys.
Good afternoon, sir.
Yeah, yes, sir. Yeah. Um, yeah. So I think the network has been dealing with us. So we just see what we can do. Can you see my slide, please?
Yes, we can see the interface.
All right. Yeah. So let's get started. So good afternoon, everyone, and I welcome us to another sections of our acute care physio essentials. And I guess this is the second to the last. So let's crack on. Let's get the ball rolling. So today, what I actually plan to discuss, or the discussion I actually am bringing on board today, is all about ward management, how we can manage the ward as a physio. So and well, um, I think before we start, there are some couple of feedbacks that was given from our previous sections. There are a lot of concerns that are raised on the page regarding the issues of certifications, regarding timing of the sessions and all of those things. There's no time for me to react to some of those things, but all I would just say is because of our time is they are all valid, very, very valid concerns, and they are very real and they are very genuine. And but briefly, what I would just say is the reality is we've got a lot when it comes to we've got a lot of noticeable knowledge gap or skill set gap that we need to bridge because physio world is a very constant and a very dynamic environment. So it's very good that we start prioritizing knowledge. It's really very good. Yeah, and we understand certifications are needed for our licensings and stuff, but priorities on knowledge are also things that we need to start thinking about as well. So today, let's get started. I'll be talking about physio ward management, and I would like to talk about how we going about getting handovers, giving people handovers, our role in screening patients, prioritizations of taxes, MDT collaborations, our scope of practices, competencies, how we maneuver equipment, and all of those things. If we have the time, I'm going to touch some of these things. And at the same time, I would also like to say that these are inexhaustible lists because our role in acute hospitals are really, really very great. And then we cannot just use a session to cover everything, but I will just try as much as possible to cover the minimum standard that is expected of us to work in acute hospitals. So let's get at it. So the first thing I would like to talk about here is about MDT involvement, getting handovers. Please, can you hear me, please? Hello?
Yes,
Yeah, please, can
yes,
you
we
all
can hear.
hear me? All right. So, and I'm sorry, I might be a bit, a bit in speed today because of the timing and stuff. So just bear with me. But when it is needed to slow down, I will try as much as possible to slow down as well. So, MDT. Let's talk about MDT. I really feel personally as a physio, as a Nigerian born and trained physio, I really feel this is what ideally this should be one of our biggest plays in hospitals, especially in acute hospitals, where we can get people to know like our capacity, where we can get people, where we can make our contributions, fantastic contributions for patient care, where we can also learn from MDTs, other members, where they can also learn from us as well. But unfortunately, this is one of the domains we don't really prioritize, or we don't really think of, due to a lot of reasons, like a lot of limitations, a lot of challenges in our healthcare system. These things is really, we are not really very involved in these things. And then just yesterday night, I was on call with some of our leaders in Nigeria in physios, and there are a lot of concerns that are also raised around this side as well, about maybe physios, maybe they even bring invite to our to our clinic, asking us to come for MDTs, maybe due to some reasons we feel like, yeah, we don't want to attend, or we I know there are a lot of limitations, a lot of challenges, but let's focus on what we can control here. That is what the discussion is all about, yeah. And again, in some settings as well, where physios can, maybe they just go for a few weeks or few days and they stop going there, maybe because we feel like we have been left out in some discussions, or they feel like we are not being carried along, or things like that. But these are all I would say, very unfortunate things, because we are dealing with life, we are dealing with humans, and so let's just see how we can touch us on knowledge about how we can go about things in the MDT as a physio. So what I will be speaking here, of course, I cannot cover everything here, is all about when we go for MDT generally, what do we need to be extracting from their conversations? Or what kind of questions do we need to be asking them? And what do we need to be reporting to them as well? Because we need update from them, and as well, they also need update from us. We need to be talking to the doctors, we need to be talking to the nursing staff, we need to be talking to the speech and language therapists, we need dietitian, nutritionists, we need to be talking to our fellow colleagues, and they need to be talking to us as well, because we play a very, very critical role when it comes to patient care. Sorry. So let's say, for instance, now the discussion is all about medical diagnosis, for instance. Yeah, of course, physios. What do we do? Yeah, we want to listen to them. They are medical, of course. They're going to be making the medical diagnosis and everything. We want to be listening to them. We want to listen to their patient background, their comorbidities, and in our head, what are we doing by listening to all of those things? We are trying to correlate with physios. We are trying to understand the patient clinical acuities. We are trying to understand the patient, the stability, the clinical stability of that particular patient. We are trying to correlate. And if there is need for us to ask questions, there need already in our head. We're already making link with our physios. Oh yeah, this is this patient. They've got background of maybe stroke, 20 years stroke. Now they are in the hospital. Yeah, this, and that. Okay, could there be limitation in their mobility and transfer on the ward? We are already making those things in our head. They're going to be having discussion around blood. They're going to be talking around blood. Yeah, the HB is low. Yeah, we're going to transfuse him. We're not transfusing him. Already in our head, while they are saying all of those things, we're already making correlation with our physio. With low HB, they might be fatigued. They may have physiological reactions. I'm not going to see them. Are we asking them questions like, if we are transfusing them, when are you transfusing them? What is their HB? When it's asking them those kind of questions, we are already in the conversation. We are already solidifying our rules with them. They already know, we understand blood. They already know now that we also do those basic anatomy, physiology, and all of those things. So we need to be putting those knowledge into practice. They are talking about patient platelets, for instance, now. Why is the patient dropping? You already know as a physio, patient in acute hospital, they've got maybe infections, their platelet can be dropping, it can be going high, the platelet is dropping. Okay, what is the acceptable range? Have you asked them those kind of questions if you need to do your stuff? Because you understand, some of them might even ask you, how does platelet relate with physio? You want to also explain to them, you want them to learn as well. Yeah, because platelet, if it is too low, they can spontaneously bleed, things like this. Also, we need why they're having those kind of conversations, we're already correlating those medical stuff in our head, and we are asking necessary questions. We are asking them about acceptance range. We are asking them about maybe mobility restrictions or precautions or anything if the patient is going in for surgery, for instance. Yeah, you want to listen to the patient medical background. You want to listen to of course, their exercise, their functional background, because these are all things they also need as a surgeon, for instance, now to make decisions for a patient before they walk in to the theater. They will also need to ensure that a patient is fit. The demographic features are very good because it's not everyone that can tolerate an anesthetic agent, for instance. So you want to also think in your head as a physio, do we need to pre-op them? Do you need to do some pre-rehabilitation for them before they go into the theater? All those kind of things. These are areas, these are domains where we can actually key in when it comes to patient care. And aside from all these things, suppose you are having discussion, you are with the RENA team, for instance, now MDT, RENA team. What kind of questions you want to be asking them? Oh yeah, when your patient is likely to have dialysis? Then when do you want to see them? You also want to communicate these things to them, because you understand your patient presentation post-dialysis might be different from pre-dialysis. Or when do you want to see them? Is it during the dialysis? Is it after the dialysis or before the dialysis? And you're also communicating some necessary blood criteria to them as well. If you are not happy with anything like potassium, like sodium, if we don't learn some of these things, it might be actually difficult to actually go into MDT meeting and be making impact. It's going to be difficult because some of this stuff, some of this blood, some of the scan are also related with physios. We need to know cautions. We need to know red flags. We need to have good understanding about herbs and all of those things. So now, aside from that, what are those things you can also communicate to them as well? They need us. They need updates from us. Suppose you've gone to see a patient now, is a stroke patient. For instance, let's say you are working on a neuro ward. You've gone to see them. They've got this very bad spasticity. You've been doing your passive stretching, splinting, and all of those things. They are not getting better. And you feel like, you feel like, oh, it's the infection. And you are looking at their inflammatory markers. The infection is not settling. It's just spiking, going up, uptrending. That could also be making the spasticity worse. Do you want to feed back to them as well? Oh, I feel like this is the infection, I think is having correlation with this. What are you guys doing on this? Or you feel like, I think the spasticity is not really getting better. I'm doing everything we can within our domain. It's not improving. Can you also work with them if they can give patients some antispasmodic agents, some Botox or baclofenes or whatever they want to give, and you combine that with your physios? Are we saying all of these things to them? So these are areas. So I feel like beyond lot of challenges, we also need to look inward, look at our knowledge as well as a physio. What do we need to improve on because if you are going in to meet a consultant, to have a sit-down discussion with consultant, you must also be able to demonstrate some level of knowledge. Not going there to be moving muscle insertion. These things are not very, very 100% relevant to patients. We need to be able to look at patients' criteria, patient information, looking at their blood, their scan and everything, and come up with a good clinical reasons why we feel this has to be done and things like that. So weight bearing tolerance, things like that, MDTs, of course, they're going to tell us about weight bearing, full weight bear them, partial weight bear them or something. How about the tolerance? Because we're going to be going to the patient side and be doing those things with them. Are we feeding them back in the MDTs as well? Oh yeah, we try to full weight bear these patients. It's really, really, no, they are really struggling to full weight bear. I think the pain is really terrible. What do you want to say about, well, I think it could be that, okay, do you want to prescribe some pain medications? Do you want to, then you speak with the nursing staff, you speak with them. However, if they give maybe some certain, okay, you'll be coming in to see them. However, if you give pain medication, maybe half an hour before you come in to do your physios. These are conversations we should be having. And doing all of these things, what you are doing indirectly is you are solidifying your roles. You are making them know that you know things and you are enhancing patient care. And you are also learning. You're going to learn a lot. If you sit down with consultants, the nurses, the dietitians, you're going to learn a lot and they will be learning from you as well. So these are some of those basic things that is expected. Why they're having those conversations, Why everyone is having those conversations, you are synthesizing those information in your head, you are connecting it to your own role, and you are also feeding them back at. Or you've gone to see a patient. Currently, they are very unsteady with the frame on the ward. What do you want to say to the nurse in the MDT? Oh yeah, well, yeah, you want to say, yeah, they are not very steady on the ward. They are not, and you communicate functions, not muscle strength and power. The power is too, no, we are not interested in that. What everyone is interested in acute hospital is patient function. Physios, you are providing update about their functions. Oh, they are now getting out of bed. Now they are now mobilizing to the toilet. Now they can do stairs. Functions, ADLs. That is what matters. That is what they want to hear from us. And aside from that, because of time, we'll talk about the other one here is about patient flow. Another thing here, very, very unfortunate. Sometimes in Nigeria, we go to see a patient on the ward, and when we get there, it could be like patient has been discharged. Patient is no more on the ward, and we go back. These are very, very embarrassing things to our profession, honestly speaking. What are we doing to stop some of these things? Yeah, it's not to be fighting people. That is not what I'm saying here. Yeah, we can challenge some unhealthy things we don't like on the ward or something. Yeah, that's fine. But what are we doing knowledge-wise to stop some of these things? Because when it comes to patient discharging patients, physios have got a lot of things to do. We've got a big role to play in this. Why? Because imagine somebody that have come to the hospital, they've been poorly in bed, they've not been eating, drinking for a while. Now they are medically stable. How are they going to cope at home? They are going home. ADLs, physios, how are they going to come at home? How will they manage their toileting, washing, dressing, everything? How are they going to manage that at home? And the medical team have decided to just send them home without physio input. And we all go back to our office. Now they've been discharged. We have come to see them on medicine ward or on elderly care ward. We get there, down there, surgical ward. The patient has been discharged. We all go back to our office. What are we doing? What are we doing? Are we truly providing that harm-free care for our patient? So we need to be asking ourselves some of these questions. So what are those things? So what does it mean generally as a physios? I will still talk about that. How some of the ways we can use knowledge-wise to change some of these things. I will still talk about that. But now, suppose the discussion is on discharge, patient discharge. What do you want to listen to? Why having this discussion? Of course, they're going to update you, medical team. They should be updating the patient because the goal of everybody in acute hospital is getting the patient out of hospital safely. That is the goal. So part of the discussion should revolve around patient discharge. So now you want to listen to, they are likely to be discharged tomorrow. They are likely to be discharged next week. They are approaching medically fit for discharge. That information is very important to you as a physio because you don't want to delay discharge. And at the same time, you want to ensure that your patient have got everything in place, equipment-wise, your physio, your rehab, their follow-up plan, everything has to be in place before they leave the hospital. These are some of those things we need. So paying attention to that is very, very important. So what do you want to update them as well as a physio? Oh, you want to update them? You want to update them regarding, your own role. My patient, they've been sitting out in chair. They've been getting out of bed. Functions. They've been getting out of bed. They've been mobilizing to toilet. No, they now have power over 2 in the leg. That's not because if they finally discharge them from the hospital without you checking those ADLs, without checking their toilet transfer, without checking if they can do stairs, if they live at home, if they live upstairs at home. So how are we sure we are? So what it means indirectly is that patient might likely struggle at home, or it might likely be a very huge burden on their family members. It could have been something we could have even solved with just simple equipment. I'm going to talk about equipment in a GV. So these are some of those stuff you want to communicate to MDTs. You want to communicate them about their trajectory of their rehab, or any limitation. I think the cognitions have been limiting our physio. They've been very confused and agitated. They've not been following instructions. The pain have been limiting. Anxiety have been limiting. Is there anything you give? Or when you even go to their bedside, it could be you picking up that pain. It could be you advocating for your patient. This is a cord injury patient. They've been in bed for a while now. What we are trying to sort out is their equipment. Many patients, there are a lot of patients in Nigeria that cannot even leave the bed. Still, they have been discharged. They've been discharged. I'm fine. And some of these patients, good. Some medical team can be fair enough. They can send referral to outpatient. But how about them popping first at home, even before they start coming to our outpatient clinic? So we need to start thinking about some of these things on how to stop or how to get involved when it is needed. So moving forward, because of time, talking about holistic care for patients, like different MDTs will be there, nutrition team will be there. You want, or if they communicate, if the conversation is about nutrition, nutrition play a role in physio. If you are not eating well, you are not drinking well, you're not going to have that physical reserve, that strength, that physiological reserve to do physios. It's going to limit your impact. It could even be nutrition, your nutrition that is hindering your progress in rehab. All those kind of, if you're not drinking well, you're not feeding well, or you've got constipation, you can even be confused. If you are confused, it's going to impact us as a physio. It's going to impact whatever we are doing. And our OTs, are they there as well? Are they also updating the team, the medical team, about how they are trying to progress patient cognition? This is one of their big roles. All of these things needs to be done. So aside from nutrition, what about SWOT team, speech and language? Are they also there? Are they doing their job as well? So all of these things, we need to start looking into some of these things and see. So what I'm trying to say here is, so when we go to MDTs, you want to listen to their patient medical diagnosis, correlate that with physio, their scan, their blood discussions. We've already have training on none of those things. You want to also feed them back the holistic care of patients. When it comes to discharge, you've also play a big role when it comes to discharge. All right. Am I making sense? Are we there, guys? Can you hear me? Hello?
Yes, we can hear you.
All right. All right. So let's move forward. So this slide here, I'm not going to go through this because of time. It's just further providing some of those things we can be extracting or we can be relating back to the MDTs. So the other thing here that I would like to talk about is how we get handovers, quick communications with MDTs, or it could even be your colleague. It could be me now. Maybe I'm in, for instance, now suppose I'm in acute hospital and I've got a colleague working in outpatient facility and I want to hand over a patient. How do we do that? There should be a framework. There should be a quick things I can quickly say, and the patient can have maybe 80 to 90% of the patient information. If you even need to go through their record, now it could just be you checking some few things. SBAR. How do we do that? Situations. So, of course, you want to introduce, yeah, my name is Sherif. I'm one of the physios working on medicine ward or working on surgical ward. Yeah, is it all right if I quickly hand over a patient to you? You take the patient name, the hospital number, so that the person will know who you are talking about. That's very important. Then what is the patient's current situation? Yeah. So this patient is med fit at the moment. So they'll discharge from our facility tomorrow. So this is what we've been, their current presentation. So they came with vomiting and this and that. They came in with weaknesses in their lower limb. This is the situation first. Then the patient background. Yeah. So they've got a past medical histories of COPD, hypertension, diabetes mellitus, and all of those things. So in the hospital, we've been struggling with their hubs, their heart rate it's been jumping up and down. Give those information, their background, their hubs, their post-op, their current treatment, what you are doing currently with them. You provide those things as well. Yeah, then the assessment. Oh yeah, so we've had a couple of physio sections with them. We've been trying to functions. Yeah, we've been trying to do some sit to stand practices with them. So but they've got some maybe significant weakness in the left lower limb, maybe power of 2/5. Function first, relate functions, because that is what matters. Even at the outpatient facility, functions is very important to us as a physio. Getting patients to do both basic activities of daily living and their instrumental activities of daily living, very important. So your assessment, so recommendations. So yeah, so I feel like the goals we've jointly set in the hospital is this to be able to work. The goal with my patient to be able to go to church, to be able to go to work, to return back to their job. He's a lovely man. Is this and if it's difficult, you say it. Yeah, it will be. It's no because of their presentation at the moment, their cognitive history has been difficult. You provide good handover, and if you're handing over to a doctor, you want the doctor to come and do something for you. How do you say that? You can go with this. You can go with this. Yeah. So my name is this. I've got a patient bed too. They came in, the doctor is requesting full information from you. You can use these things as well. Oh, their background is this. They came in with this, and that. So I went to their bedside. They're having, they're currently on 40% FiO2. Their respiratory rate is this. I've done my assessment. It's not physio amendable. Is it all right for you guys to come assess? It's not. There's nothing I can do for it. All these kind of things. By the time you go with this kind of framework, the necessary informations to give to the person, to the receiver of that information, they will appreciate and they will have the good clinical pictures of what you are trying to pass across, if that makes sense. All right, so this picture here is also further providing information to what I just explained. I won't go through this because of time as well. So we move to the next one, ward screening. How do you screen a patient in the ward? Yeah, let me just quickly look at the chat box. Let me see what guys are in there. Yeah, sorry, just reading the chat box just to see feedback if there's anything I need to quickly adjust. All right, so now let's move forward. What screening? This is one big rule we are not doing yet in our country. We shouldn't be shying, like we need to be talking about these things. You see now, there are a lot of patients that are leaving the hospitals without physio contact. That will be having physio contact, but they are not having physio contact. But in the end, what do we do? Physios, what do? We blame people that are not trained to be a physio. We put every blame on the medical team. Oh, doctor, they didn't refer them to us. And you are in the office, you are drinking tea. That's supposed to be. You've got equal duty of care that a doctor have got to a patient, that consultant have got to a patient, that nurse have got to. You've got the same duty of care to your patient. In 2026, physios, we are well-trained people. We should be able to go to the ward, look at the patient's note, do your screening, decide who you can see and who you cannot see. These are stuff we should be doing, or these are stuff we need to be doing for us to get that optimal respect we need from other members of the MDTs. Yeah, even in West, for example, yeah, in NHS, for instance, consultants that have been working with physio 20 years, 30 years, you still see them asking you to come and see chest physio. And by the time you get that, you just get few information from chest. This is not chest. You even start educating them. These are people that have been working with physio for many years. So what I'm saying is, these people are not trained to be a physio. And we are not also trained to be a medical doctor. So it is right for them. Yeah, I know not getting appropriate referral or not referring a patient, it could be ego-led as well. I'm not talking about that. But here, knowledge, let's talk about knowledge here. Yeah, these people are not trained to be physio. There are a lot of patients that need physio that the 100% chance is there that they may struggle to identify those patients for us. So we need to start thinking about how can we start going to the ward to start to do regular screening. I think the DPT program that we have at the moment, these are some of these things that this program are supposed to be, are supposed to be providing us adequate information about our gap, honestly. So in 2026, we should be able to be doing that. For patients, they've come to the hospital, you should be able to look at their background, look into their blood, look into their scan. Yeah, if they are waiting a scan, you need to hold your physio for a while. Maybe scan for head or scan for lower limb to know if there is a fracture or not. You need to know. If they have been seen by a doctor already, when they come in, they run the scan, X-ray, whatever thing, they've been cleared by the medical, do your stuff. Look at their blood. You don't need to wait for a medical team to write a referral for you on that before you do your stuff for them. Respiratory problems. How can we screen them? Yeah, what are the indications for you to intervene in a patient respiratory wise as a physio? Maybe 4 things. Yeah, have they got sputum retention, loss of lung volume, work of breathing, or respiratory failure, either type 1 or type 2? Can we identify these things? If you're able to identify these things, these are your patients. Lot of patients in this category we not even have physio contact. A lot of them are dying because nobody in acute hospitals except physio can successfully manage some of these patients. Let's think about these things. Patient with neurological deficit. What is the stroke guidelines, the national guideline, WHO guideline, anywhere in the world? What is the recommendation? Day one, after the onset of their stroke, start doing your stuff. Do I now? That is the guidelines. That is the standard anywhere. That is the standard. So does it now mean I need to stay in my office until the patient is now medically fit? Medically fit. What are you saying? You are waiting for a patient to be medically fit. That means the initial treatment that you are supposed to be giving to that patient, the early neuroplasticity that you should start doing your stuff to promote those early neuroplasticity. You've depleted your patient of that care. That's what it means. Day one, day two, you should be able to go on the ward. Look at the note, look at their presentation, look at blood, everything. Speak with the medical team and start doing your stuff. Domains, functional domains, or patients have been admitted because of anything, any medical or anywhere in the hospital. They've not been out of bed. Day one, day two. What are you doing as a physio? Go there, go get them out of bed. Anything could be restricting that. It could be pain, it could be nutrition, it could be cognition, it could be anything. Think about all of these things. How about their personal care, their hygiene has changed. Normally, they're able to do washing and dressing, they're able to go to the toilet. Now they are in the bed. They are needing their family member or nursing staff to get them washed, to get them dressed. They need physio. They need OTs, or their cognition has changed. They are now hallucinating, they are shouting, they are agitated on the ward. What are the OTs? What are they doing? So these are some of the stuff we can be using to be screening our patients. Because of time, I might not be able to go in depth of all of these things. All right, these are just some of the neurological stuff. Because of time, I might not be able to touch on this as well. But if we read through, I'm going to send the slide. It's going to give us some clue. So we need to start thinking about these things, how we can further develop ourselves, how we can lead some of this care in our different places of work. All right. Again, this slide is also providing information to that. Just what you can do if you're in auto ward, how you can screen them, who should be screening in. So they are very well explanatory. Because of time, I may not be able to go through this as well. So yeah, I'm going to touch on this briefly. Postoperative screening, respiratory screening tools. Suppose you've got a patient now, you work in maybe cardiothoracic, or you work in or you've got some patient populations that have gone to do abdominal surgeries or something like that. So you want to think that would tell you, do you really have to see this patient or not? You need to be looking into their risk factors. Look into things like, the BMI. You need to check in nursing chart. Get their height, get their weight, look at their BMI. What is the age of that patient? What is their previous chest conditions? Have they got any previous chest conditions like COPD? Are they heavy smokers? Are they MS or whatever? Or neurological conditions that can impact their chest, like a spinal cord injuries or anything like that? Look into their operation notes. What is the duration of anesthetic they've had? 4 hours, 5 hours. How is that related to physio? Imagine somebody that have gone for surgeries, 5 hours, big surgeries, laparotomy, Whipple surgeries, head and neck surgeries, oesophageectomy, for instance. That duration, that long time in the surgery, in the theater, what does that mean? What does that mean? That means with an anesthetic agent, the chances there that they can have a reduced lung volume. The chances there that while having that surgery, they are being sedated. So they are not eating, they are not drinking, they are dehydrated. What will happen to their mucociliary escalators? It's going to be dry. Their airway is going to be dry. They are prone to secretion retentions. You start linking things up in your head. Again, somebody lying down for that long period of time, what does it mean for their chest? That is not very good for their chest. That is not very good for their chest. You start linking some of those things together. So you need to know about their durations of surgeries, the length of their anesthetic, the type of procedures they have. So all of these risk factors, then again, their previous exercise tolerance. They are normally independent, very active. They go for work, they go to their work, they do clubbing, they are this, they are that. You look into those things as well. Elderly patient, they only do stairs at home. You correlate some of these things and you now make a decision. For you, do I really need to see these things? Do I really need to see this man or not? Oh yeah, are they currently on oxygen? What amount of oxygen? 2 liters. Oh, I'm not very worried. Oh, if other risk factors are fine, I'm not very worried. Oh, somebody on 40 liters, 60 liters. I have explained, we have had trainings on oxygen and blood. I won't talk of those things again. How about screening their delirium? You are looking at the nursing note and you are saying, yeah, patient is confused, they're agitating and stuff. They're agitating, they are confused. You see, yeah, when I was having this kind of discussion with people yesterday, like, yeah, it's very possible that even when we look at the nursing note, some of these things are missing. This is when we can come in, educate them as well. This thing is related to us. Can you guys start doing these things? It's everywhere. There are a lot of trainings I have had for nursing staff on the world. There are a lot of training that is already done for me that I'm going to do with them this calendar year as well. There are a lot of training that I'm going to attend. I'm going to attend some NDT training done by doctors, done by nursing staff that are related to their own stuff. This is when we can come in again, teach them some certain things. Oh yeah, can you start doing these things? Can you start? We work with it. So that's that. So we need, if patient is confused, they might be needing notice. If their social history, you look at their background and you find like, okay, even before they come to hospital, they are struggling, they've had many falls. You've got good reasons to see them. All right. Are we still there, guys? Can you hear me?
Yes,
Hello?
sir.
Yes, sir, we can hear.
Yeah, am I making sense or it's just boring? I'm just speaking unnecessary things, or what do we think?
So it's clear and understandable. Thank you.
All right. Can I get 2 more persons to do that, please? Can I just feedback, please? Just feedback. Yeah.
Yeah, it makes sense. We're understanding you.
All right.
Very
Thank you.
understandable.
All right. Thank you very much. Yeah. Yeah. Before I speak to this slide, I want us to do something now. Let us take a moment. It's not important if I finish this slide, but spending few times together and having good clinical discussion is better than length of discussion that we have that we cannot even gain things there. Can we just have a moment? Let's have some clinical reflection now. Just think about a time you have gone to the ward and a particular patient is discharged. Think about what you actually plan to do for that patient. Think about like how you feel as a person. Just like, how did you feel? Did you feel anything or just normal thing? Oh yeah, move on. Yeah, they've gone. That's it. How do you feel as a person? Just imagine if it was maybe any of your family member that was in that position that was supposed to have that particular physio, that they didn't have them and they are being discharged from the hospital. So how do you feel? And what do you think we can do better? Like, what do you think we can do better? We are professionals. So what do we think we can do better? You can open your mic and just speak up. Maybe 2 persons and we move on. 2 persons. What do we think? Or and if it has not happened before, if you are in the facility that everything is working well, you are getting involved, let us know. Just speak up. Yeah. If things are working well in your facility, just speak up. And if it's the other way around, what do you think we can do better? And how do you feel? Yeah. Who is there?
Let me just give a scenario.
Yeah.
It's just like you get an invite to teach crutch walking, and then you make all the preparation. Maybe by the first session, the patient is in so much pain and is not even responding or learning. And you say, okay, go and rest. We continue tomorrow. Then only for you to come the next day and they've been discharged. And this person hasn't learned jack about crutch walking, 1, and 2, there's definitely going to be accident. This is an accident going to happen at home because he hasn't picked up. In your mind, you'll be like, now, how will these people manage at home? How do you transfer from the bed to the chair or from climbing the stairs? There's this thing that you'll be like, it's painful that what you wanted the patient to achieve wasn't achieved. 1, you feel so disappointed. And then there's that painful aspect of, is it that the doctors discharging don't understand that we should certify the patient fit for discharge.
Yeah.
Because if he hasn't learned the crotch walking, they haven't learned it, and perhaps there's an internal fixation and there's a fall at home. It's a repeat surgery, and it's the patient that will foot the bill.
Yeah.
Why isn't that put in consideration? So it's not a scenario that you would like to have as a person.
Yeah. Thank you very much. That is a very good clinical reflections, honestly. It's really very sad being human as well. This is from financial point of view is really very sad. From safety point of view, anything can happen to this patient at home. It's really very sad. And from our perspective, how can we stop some of these things? Stopping some of these things, I know we have complexity around our system, is us getting involved as well, like in MDT, especially in discharge planning. We need to solidify our roles when it comes to discharge. Physio, in fact, in NHS, most of the discharge you see, they are physio-led. Why? Because it is physio that will tell you, yeah, this patient will be safe at home. This patient can do bed transfer. This patient can transfer to the toilet. This patient will need equipment in the toilet. It's the physio that can tell all of these things. So most discharge in our hospital are supposed to be physio-led. Just imagine the case you just gave now. The patient can go home, they can struggle at home, they can fall. Anything can happen. All right, can I get one more person, please? Just one more person before we crack on. One more person. Because of time, let's speak up. Yeah, one more person who is there. Just share your yeah. Somebody have said in the chat, thank you. With the blessing relating into what is being said, physio should be consulted or informed before a patient receiving physio treatment is discharged. Yeah. We also need to be discharging those patients from our end before they go home. Yeah. So all right, can I get one more person? One more person, please speak up, speak. Clinical reflections, just speak up. All right, maybe I'll just continue because of time. So yeah, so if we are saying now that we want to be going on the ward, we want to be doing patient screening. Yeah, you can open your mic. Your hands is up. Open your mic. It's a Mulikat. Open your mic. Yeah.
Thank you, sir. Regarding what you said, though, in my facility where I work, there was a patient in the male medical ward. So the patient, I think the physicians were managing the patient at first. So they are done with their own part. The patient is okay, but he's unable to stand because of severe knee stiffness. So he could not stand. So they didn't just discharge. The good thing is that they didn't just discharge the patient. So they actually called us. They invited us to start the management. And they told us that when we are done and we are satisfied with the recovery, we can discharge, that they are done with their. So I was really impressed.
Yeah. That is a very, very positive one. Yeah, that is a very, very positive one. Brilliant one, honestly. Yeah. Our role in that facility is really, really very well solidified. Yeah. So that's very great. So what do we want to do as a physio as well? Because of physio needs, we don't want to like hold the discharge, like delaying the patient in acute hospital, because we know this is a very, very infective environment. So as much as we can, we do our stuff. What do we want to do? We discharge them, we give them our outpatient follow-up, we crack on in the community level. Because the data is also there, because that is also why when we also what's it called now? If we are having those discussions with the medical team as well on this guy, we also need to be saying some of the things. If they are saying a patient is ready, then we should be ready as a physios, and that is why getting involved at the initial stage is also very important to us as a physio. Because if we get involved in the initial stage, we are started in our stuff. Now, before they say the patient is med fit, the chance is there that we could have actually progressed the patient to a near level, like near stable level the patient can function at home, to a level that the patient can start coming to our outpatient facilities to start doing their stuff in the outpatient, to keep progressing their stuff in our outpatient facility. So thank you very much. That's really a good one. So let's just crack on because of time. So so as much as we are saying 2026 physios, we should start thinking about going on the wards, picking up patients and start seeing them. We also need to understand some of this stuff here. If they are saying, if a medical team, in the medical team, they have written that a patient is on palliation, something will ring up in our head. Things like, oh yeah, it could be now that, oh yeah, maybe they've got a few months to live. So what should be your priority as a physio as well? The priority, the discussion you want to be having with the patient at the bedside should be, what is their goal? What do they want? What do they still like to be able to be doing? Comfort. Attention is on comfort now. Oh yeah, you want to ask them function, tie it to function, not strength, leg strengthening, range of motion, or so tie those things to function, because that is what really matters to you as a physio, and what really matters to the patient as well. Tie those things to function. Yeah. Oh, do you still want to be able to stand? Do you still want to be able to walk to the toilet? And again, it's very possible that patients are saying a lot of unrealistic things. For instance, a patient that is really very poorly, that they currently need assistance of 2, assistance of 3 to roll in bed, and they are saying to you, and the medical team are saying, oh, they've just got, in fact, they have started progressing from palliation to end of life, and they are saying their goal is they want to be able to walk on the street, to walk to the market. So you want to now start educating them. Don't give them that false hope. Don't give them that false hope. If they're asking questions around medical needs, you get them, you tell them to speak with the doctor. So you want to just tie those things. You are looking at the medical plan, and you are using that medical plan to restructure your own rehab and to restructure the conversations you want to be having with the patient. That is not the time to now start bringing false hope. If you are doing that, what you are doing indirectly is you are started working against the medical plan. And again, that might not be a case for the patient. So if they say to you that a patient is currently on AMBA pathway, what does that mean? AMBA means, their condition is also very uncertain. They might recover, good. They might deteriorate. That's bad. That is what it means. And again, AMBA means, they are for active treatment. Doctors are still doing their stuff actively for them. So physios, you can also do your stuff actively for them. That's what it means. AMBA. So, and again, AMBA could mean like the patient is for what basic ceiling of care, that their care is just for the ward. Like they are not for ITU escalation if they deteriorate. It also means that. So when you read the medical notes, or when you speak with the consultant or the medical team, and they are saying, oh, this patient is here, is there, is on AMBA, you already know what that means. Yeah, they are still doing their stuff actively. So you need to be doing your physio actively, because they need that physical functions to optimize their medical needs as well. And they also need medicals to optimize their physical needs. Oh, and if a patient is on high plan, that's end of life, or they're actively, that high plan could mean maybe they're actively dying. Do you still want to be doing stuff with them? Do you still want to start doing any goals? Let's design rehab goals. No, just leave them. Comfort. You need to prioritize comfort. Because there is no rehab you want to start doing in that regard. There is not somebody that is even actively dying. Do they need any rehab? No. So we need to be able to pick up some of these things. So I crack on because of time. So the other thing here I would like to discuss. Imagine now we started going on the ward, we're picking patients, we're doing our stuff. Even right now, I'm sure we all have this wide caseload, like 2, 3 patients, 5 patients that we need to see, and we've got limited staff. How do we do that? Prioritizations need to be well understood. So in acute hospitals, you might need maybe on your ward, same ward, medical ward, you've got a chest patient there, you've got a patient that is just for rehab, they are laughing, they are sitting out in bed, in chair already, the family are, no big concern with them, or you've got a post-op patient there or something like that, and at the same time, you've got a family meeting by 12, or you've got a presentations, in-service training by 12 or something. So we need to be able to prioritize. You cannot leave a patient, a dying patient that needs physio, chest physios on the ward. You cannot leave them and say, yeah, that student training, you can divide that to another day. We need to pay attention to patient first. So generally in acute hospital, how do you prioritize? Generally, you do that in order of the acuity. You do the chest first. You do the discharge first. Discharge, get them out of the hospital. Like I said the other time, once a patient is med fit, you do not also want to delay their discharge. That is why getting involved at the day one is very important. Start doing your stuff as a physios. Immediately they say they are med fit, you don't want to delay them. Now, yeah, if there is need for you to advocate for your patient to still be in the hospital, let's say for instance, now the chest pain is still really bad, you can speak with the medical team. Or if they're still waiting for equipment, they've got cord injury, for instance, they're still waiting for their wheelchair, and you know this patient is not going to function at home if they don't have the wheelchair before they discharge them. So if there is, so think about those things. You can just say, oh yeah, maybe buy 1 or 2 days, but you also understand in your head that long-term hospital stay is not good for your patient. They can catch infection, nosocomial infection. They can decondition in the hospital. They can have DVTs and all of those things. So how do you prioritize? You do chest first. You do discharge first. Then you now see new patient first. New patient. They just came in yesterday. They had a fall. You need to see them. It's your patient. They've been cleared by the medical team, no fracture, nothing. You need to see them. Design your full contingency plan with them. Talk them through something. That is, so all these things very important. So discharge patient, what is it again? New patient. Then other ones will follow rehab. Do your rehab, your regular rehab. What we are just trying to work out with them is their sitting balance, is their standing balance, is them mobilizing few more distance. Then those one will now come first. If you look at the case study here, if you look at the case study here, the first one. So I don't know. If you look at the case study here, the first one says you've got patient, they want hip replacement, and one of them is med fit, one new patient due to fall, and you've got family meeting by 12. Who are you? I think this is a very straightforward one. Who are you going to see first? Who are we seeing first? Can somebody answer that? Who are we seeing first? Yeah. Suppose this is you. This is just you now. This is your caseload. Who are you seeing first? Because of time, let's just take that and I will take one chest here as well. So who is answering that for us? The first one. Who is answering that? Please open your mic. Time is gone. Pop the answers in the chat box as well. Who are we seeing first? Yeah. Hello. Can somebody hear me? Hello.
We can hear you, sir.
Yeah. So
Can hear you, sir.
Yeah. Who are we seeing first here? Suppose this is your caseload now. Who are we seeing first? Who is answering this? Like in that order that I explained, you see chest patient first, you see discharge, you see the new patient, yeah. Then you see the other ones, rehab and stuff. It's as simple as that. Some people, there are a lot of framework. I don't want to start, I just keep it simple. There are a lot of framework we can use for prioritization, but let's keep it simple now. Let's keep it simple. Who are we seeing first? Yeah. So yeah. Let me read the chat box because of time. Yeah. Somebody said case 1, case 2, 2, 2, 3, 2, yeah. So yeah, who are we seeing first? Let me just drag this away. Yeah. So what are we seeing first? Yeah. Day 1 hip replacement. Day 1 hip replacement, med fit, new patient, the new patient with a fall and family members by 12. Who are you seeing first and why? Please open your mic. Yeah. Also pop that in the chat box. People have started responding. Thank you for that. 3412. 3412. Let me check that out. 3412. 1, 2, 3. 34. New patient. 34. Okay. So what are we saying first? Let me answer this because of time. Generally, you want to see the hip. Yeah, you can depending on if you read the caseload. Let's say for instance, there is no direct. Let me also say this: there is no direct way to this thing. It's all about your clinical reasons. Forget about what I just said now. Generally, I don't even remember that when it comes to my caseload. I just look at my caseload, quickly do a quick screening on everybody. Yeah. And I will start seeing them. I will crack on. Now, look at this here. It depends on clinical reasonings. Yeah. Yeah, I can easily say, let's say MedFit now. What is still delaying this man in the hospital? No big thing. It's just to give them frame and go home. I can sort that one out and go away. It could be as simple as that. And then they want hip replacement. Hey, a very poorly man. He's been really, really very chesty. High amount of oxygen, 60% on the ward. They are not coughing and clearing. That is what the nursing staff have handed over to you. Do you want to leave them and you want to go to the bedside of somebody that is now MedFit? And maybe we need to write a community referral or physio outpatient referral for them. Is that what you want to sit down and be doing? When you've got a man that they can die of respiratory failure on the ward. It depends on, this is just clinical reasoning based. They want hip replacement. We know, yeah, they've been in the theater, they've anesthetic agents might be dropping their blood pressure, might be affecting the anesthetic agent, might be affecting their chest, might be impacting their chest, lung volume. Anesthetic agent might be affecting their heart rate, and just relate those things together. And again, you also know as well that what does the guideline says? They want post-op. ERAS protocols, early recovery after surgery. Get them out of bed, they want. That is what the protocol says. So what do you want to do here? So you might want to just do one first, then do the MedFit, sort out the MedFit, let them go, because you don't want to delay them in the hospital. You need to also sign them off. In an ideal environment, physios, you also need to sign them off before they go. So think about all these things. Then you now start seeing a new patient. You see your new patient. If I have the chance, or if I've got junior colleague, these are when we need to also know people's capacity as well. Prioritizations. Know your staff capacity. Oh, I've got a very Dr. Abubakar is a very, very stand physio. He knows his stuff when it comes to chest. Yeah, Dr. Abubakar can go see the test patient, hip replacement, get them out of bed, do their stuff. Can go start. The MedFit patient is just give them frame and let them go home. Yeah. My junior colleague can just go sort out that one. Then I can go do my comprehensive fall assessment with that one on fall, with that man that have come with the fall. And the family members, if we have the time, of course, meeting family members is also very important. We need to prioritize that as well. Yeah. If we, of course, somebody must be on ground to attend to the family member. Yeah. And if we don't have the time, we can reschedule. But before that time, call them. Oh, this we won't have this. These are just human to human relation. Yeah. I go to second one because of time. Pop your response in the chat box. Somebody have come with CAP. CAP is community acquired pneumonia. They've got background COPD on 2 liters nickel cannula. You can relate blood now. Yeah. The second patient, they are confused. They are off baseline because of their UTI. The third one, step down from ITU. If you are in acute hospitals, these are typical patients you'll be seeing on a regular basis. Typical patients you'll be working with on a regular basis. Step down from ITU. The other one is post-op following neck or femur fracture. So how do you see these people? This is your caseload. The first one, they have COPD. They have community acquired pneumonia. They are on 2 liters of oxygen. That's the first case. Second one, they are off baseline. They are off their baseline. They have UTI. The third one now is they just brought them to our ward, to the medical ward or to the surgical ward from ITU. And the other one is somebody that has the one neck or femur fracture. So how do you see all of these people? This is a very difficult thing to go about, honestly. If we are really getting involved in acute patients that are very unwell, not when they are about to leave the hospital and they now call physio come and see them. No, like I mentioned, getting involved at the necessary time. So what do we see here? Who do we see first here? It's all about you looking at your caseload. Okay, I can just look at, somebody from ITU. Yeah, I can quickly screen their notes. Oh, yeah. Is there any chest concern? Is there anything? Yeah. Because I know chest is very important. Oh, somebody from day one, neck or femur fracture. Yeah, if it's just normal mobility. It could even be that maybe on the ward. Because getting patient out of bed is not just physio's job. Nurses, these are stuff we need to also be, because if we are in, we're doing our job, we're working everywhere in the hospital, renal ward, in the gastro ward, head and neck ward, we cannot be seeing everybody. It could even be maybe just nursing staff, I even get them out of bed, and I've got one chest somewhere else. I'll go do the chest first before I start thinking about that. Okay, so look into all of these things. So what do you want to see? So the first thing here, I will look at step down from ITU. Well, how are they doing? How are they presenting? It could even be OT that is supposed to go down to see them, maybe with a PT anyways. It could be OT just checking. Maybe they are very confused now. That's what they are now. They are off baseline. They are agitating. They are very agitating and they are hallucinating. So what are the OTs doing? Maybe just combine OTs with joint section with physios. Go down to see them. Why OT are focusing on their cognition? PT, you are looking at their chest and see what you want to do with them. But if there is no big concern, somebody can also come down from ITU. Ideally, like if physio, because physios on ITU, we got physios that should be on ITU doing stuff, doing mobility, doing chest for patients. It could even be maybe physios on ITU, they've progressed them to a very, very good level, like good level now, good like mobility level. It could also be, you could just be, maybe you just go there and you just look at, yeah, they're even mobilizing already, just discharging them or something. So there is no, I'm just trying to explain these things so that we can understand what we need to be thinking for a patient. If we need to be seeing them or we are making decisions to see them first or not to see them first. All these things are criteria led. And we should be able, if your senior is asking you, or if your junior is asking, you'll be able to defend your caseload. All right. So because of time, I will not be able to go in details of some of these things, but so I will just crack on because of time. Some other things I would like to discuss is manual handlings. Manual handlings. Oh, you see, manual handlings. Maybe brief questions before I open the slides. We need to think about these things. Are we actually safely moving our patient and not putting our own health in line for somebody? Think about that thing. Just think about it. Like the transfers we are doing on the ward or we are doing in our outpatient facilities, are we actually doing those things rightly? And we are not putting ourselves at risk, or we are not malandering some of these patients? Let's think about these things. And again, the MDTs, because this is a very, very big physio domain. MDTs, the doctors, they've just done a surgery for a patient. Have we ever think about how is this patient being transported or being transferred from surgical table to the bed? How do they move them? Have we been thinking about these things? Because manual handling is a very, very big physio domain. We need MRTB policy around this part. Manual handlings. We need NSP, we need ACAPEN or whatever physio group. We need some policy. We need local hospital policy. We need physio department, to have hospital, develop hospital policy. We need to be training our MDTs, train nurses, train everybody on manual handlings, on how to move patients. Every staff in the hospital that are involved in transferring patients. Are we doing those things? Let's think about that. Because when we say manual handling cut across how patient is like basic things for ADL first, moving from bed, standing, mobility, toileting, cut across somebody that had a fall in the ward, or again, patients that have been poorly in bed. They are very, very poorly. They are not eating, they are not drinking well, they are in bed now. And they cannot stand to frame. What else do we do? And this is a very big lady. What else do we do for them as a physio? So do we just keep going to them and doing stay raise SQC and this thing in bed with them, bridging in bed? What are we doing? Is that what the evidence supports? Yeah, be doing those things, but think about getting that patient out of bed. That is evidence-based. Get them out of bed. Get them to sit in the chair. Patients that don't have good sitting balance. By the time we do our stuff with them, the sitting exercises we do with them, we still return them back to bed. What are we doing, physios? We need to be getting this patient to sit in the chair. It is not everybody that can sit in a standard chair. If we are truly working, people can be very so poorly that they cannot even tolerate sitting. Not just 2-3 minutes, 5 minutes in standard chair. They will slump down. Do we have that tilting space in our facility to support some of these patients? Let's start thinking about some of these things. I think one big way we can also solidify again what we do in acute hospitals for our patients is this domain. Physios, we need to be training those staff, train nurses yearly. Train them how to move patients. Train doctors how to transfer patients. I'm going to show us some equipment now. Let's crack on. Yeah. When it comes to, and again, generally, these are things we want MRTB, NSP, or ACAPIN, or whatever group you are. These are things we want before we allow somebody. In fact, in the West, before you start using some of these equipment, in fact, manual handling is something that can actually cost somebody his or her license if you are doing it wrongly, because this is a very big physio domain. Before we allow somebody to even go on the ward to use as simple as frame is, you need to demonstrate good clinical reasonings, good clinical knowledge. It is not all patient that can stand to frame. It is not all patient that can tolerate standing to frame. How about you need good clinical reason? Oh, they've got post-op, what equipment they cannot wait on this one, they can wait on this one, they've got stroke, or they've got this one. When is it appropriate for you to start using frame for a stroke patient? You need to start thinking about these things. What about the practical skills, the hands-on skills, getting somebody from line to sitting? Pulling is not allowed. Pulling patient arm, all those things. Are we checking these things? Do our board, Emma, do we have a good reporting system to report some of these incidents? Not so that we can come down to further train those staff to be doing those things rightly. How about risk assessment? Are we risk assessing patients? Risk assessing patients. Oh, what's the equipment? How is their home like? Our OTs, are they checking some of these things? Recently, the acute hospital, they are being poorly. They are these. Is the OT, are they working to get the patient appropriate equipment that can support their conditions they are in? So behaviors, patient dignities. With appropriate equipment, you can avoid unnecessary contact. It is not everybody that can tolerate some of the contact we are having with them, like physical contact. That's why we need some of this equipment. So communications, what verbal cues? How do you key your patients? Oh, what information are you? And when it comes to documentation, it's because of time. That's why I'm just slim fitting whatever. I could have been bringing a lot of clinical case study into this, but because of time. Documentation as well. How do we document? Let's say, for instance, now, me and PT Joseph, we went on the ward, we stood a patient to the frame. It requires maximum effort of 2 of us to get the patient to the frame. And we start the patient in the bed chair. Now I went to document and I say, oh, standing exercises and sitting in the chair. What have you documented? Is that replicable? The next physio, if I'm not in tomorrow, it means that PT Joseph is not in tomorrow. The physios that will be going into the ward to see that patient, do they know if they need to double up on that patient? Do they know from that documentation? How are we documenting some of these things? And in your documentation, again, with the equipment you've used, what have you communicated to the nursing staff on the ward? Do you want, so all of these things, what do you want the nursing staff to be doing with the patient as well? Family members, rehab is to be continuous. Rehab should not be when physio should be leading it. You should think about who should be involved in this patient care for optimum care, for optimum recovery. Who should be involved? You need the family, you need the MDTs to be involved. Time has gone. Where do we prefer here, guys? I need us to speak here. Where do you prefer and why? As a physio now, let's look deeply into these things. And you have to tell us the reasons. Hello, are we still here? Please, can you hear me? Hello?
Yeah, we can hear you, sir.
All right. Yeah, thank you. So where do we prefer here and why? Let me just get feedback on this because of time, please. Please, guys, speak up. Pop the response in the chat box. Yeah?
Okay, I would prefer the very last diagram,
Okay.
and with the aid of the equipment, because even as a physiotherapist, it helps, and it's no much stress for the physiotherapist, and then would also help for the comfortability of the patient as well.
Okay, thank you very much for that. Yeah, let me get a few more response. Yeah, response, guys. Which do we prefer? Yeah, like, and why? Why not this second one here? Why not number 2? Why not this third one? And why not the first one? Let's just clinically reason these things together. Because these are big things.
Good evening, sir.
Yes, ma. Good evening, ma.
Okay, sir. The hoist system is a lot better because
as a physiotherapist, it prevents you from going from being a PT to being a patient, because you're not stressing yourself that much, and you're not what's the English I will use? You're not like you're not putting yourself in that position where you have to start having body aches and
when you will start needing another physios. Yeah, your colleague to be with you. Yeah. Yeah, okay, thank you very much. Yeah, thank you. But why not second one? Why not second one? Why not this third one as well? I know everyone here will agree the last one is the best thing. But why not other ones? Yeah, let's speak about other ones here. Because these are stuff we see on a regular basis on our ward. At the physio, you just see somebody doing it, just look away. It's not good educations. So why not the first three? Yeah, let's speak about those ones. Why not those ones? Yeah, I'm reading the chat box, but open mic. Let's speak. Yeah, let's speak. Yeah.
Apart from the hoist, I will prefer the second one, sir.
Okay. Okay.
Because it involves two, I don't know, maybe physiotherapists, and the position the patient is in, she's sitting, and I think they are trying to get her up, so it might be easier to get her up than that person that is in the third picture, which is sitting down. So I think.
Okay. So, but why not the third one, sir? I know the patient is on the floor.
The third one, the patient is sitting on the floor, sir. And the patient appears to be heavy. I know from the picture. So it is not going to be easy to lift him up from sitting on the floor. It will be easier when he's sitting on chair or bed.
Okay.
Okay, so let me say something.
Go on, man. Thank you. Yeah.
Okay, so for that third one, I mean, there is high risk of staph injury also with that, and then it's unpredictable because I mean the patient can slip and fall with that, so I won't be using that.
Okay.
So I preferably
how about first one? Well, what do you see to first one? We are just clinically reasoning this thing together.
The first one just shows the poor ergonomics there. And then it will also be difficult for patients to control their movements. I mean, you're literally, it depends on the muscle power of that patient. You're literally carrying the patient. I mean, it's so difficult for patients to control their movements. And it's not practical enough for repeated transfers. That means anytime you come, you're pulling patients up to the floor, to the bed. I mean, patient is at also risk of falling with that. Thank you.
Okay, thank you very much. Yeah. Let me just read this one out. Mr. PT Wahab, is written that the second one would have been good if the therapy in front is well positioned. Such a position, I cannot see clearly now. So the spine will be affected due to lifting. Okay, good one. Thank you, sir. Ms. Deborah have written, and the patient is obese. Carrying him in that position will put strain on the back of the PT. Yeah, these are lovely and very sound, good clinical reasons. Thank you very much. I really appreciate our contribution. But let me just say this. Honestly speaking, this is 2026. This is 2026. Physios are not laborers. We are not laborers. Like we are not laborers. We are not trained to be lifting people. We are not laborers, honestly. So we are professionals, well-trained people, well-trained. Nigerian physios are well-trained people. So number one, off. Just imagine this lady, she's got like 3, 4, 5, 7 patients to see in a day. You've got a patient on the ward with, let's say they've got laryngectomy now, they've had tubes, line drains. You're going to see this thing live in acute hospitals, line, drains, tube, attachment, urine catheter. How is he going to manage? Is this a safe manual handling? The answer is no. No. She's going to hurt herself. She's going to hurt the patient. That's a very, very poor manual handling. If you see that report, MRTB, there should be a good reporting system. MRTB need to come down to that facility. They need to come down to train those, to the NSP or whatever. They need to come down to start training those staff. You're going to hurt your back. You're going to become a patient. In the meantime, it's a very safe. And again, how many patients are you going to be lifting like this in the hospital? How about if the patient is an obese patient? That is not safe. How about if the lady on bed does not even want that contact? How about if they do not even want that unnecessary contact in their body? Let's think about this thing. It's not safe. The second one, this is what everyone is being taught in the school. Yeah, 2-person leave. Yeah, leave. This leave. I am sorry to say that this is a very poor manner handling as well. This is 2026. Are we saying in Nigeria we do not have the money to buy the last one? Is that what we are saying? So if you are doing this, if you finally discharge this patient home, think about these things. Let's just clinically reason these things. If we finally we discharge this patient home, let's say they are in the hospital now. If you discharge this patient home and he lives with maybe one of the family member, how is he going to manage? Just think about this thing. If you are needing maximum assistance of 2 from physios to get this lady into the chair or the wheelchair, whatever you are taking them to, how is he going to manage if they get home? So the person with them at home, if they need to get them out, they will start pulling their leg. Is that what we should be encouraging? This also. So I say we need to start advocating that some of this stuff that are being taught, this stuff here that are being taught in school, we need to start gauging these things. Like this is one of them. I'm telling you, in Nigeria, right now, Nigerian physios, we need to start speaking up, getting our people, our leaders, to start advocating for the government to get some of these equipment in our facilities. We are richer. Nigeria is a very rich country. These are some of the trainings we can begin to have. Teach the what's it called now, the consultant, teach the provost in your school, teach the what do you call them, the CMD. Let them know something. These people don't know these things. This is our job. We need good regulation on these things. For these things, I'm spending time, and I'm happy to waste. In fact, to spend a lot of time on these things here on this particular slide. In 2026, physios, our lecturers are still teaching all these things. Yeah, I know. Yeah, maybe because these are expensive equipment. If you finally, because of our status in Nigeria, if finally discharge patient home, yeah, they will still be needing. Yeah, we can still teach family, but physio, we are not laborers. We should have sufficient equipment to work with in our facilities. So now, this is patient with good sitting balance. If you got patient with a very poor sitting balance, they cannot even sit in chair, and they are obese, they've got different attachments, and they are on the ward, they are on medicine ward, they are on renal ward, they are on the bed now, orthopedic ward. How are you going to leave them out of the hospital? Like, how are you going to mobilize them out of bed? And they are very poorly here. Think about these things. We have patients like that. Think about it. So we need like 4, 5, 6 page physios. Or are we even doing that? Think about these things. This one, the third one, poor manner handlings. What are they doing? They are pulling the patient's arm. Pulling. You want to dislocate their arm? This is a very, very poor manner handlings. How about if you try to teach, there are things, even if you don't have equipment, how about if you try to teach them maybe backward chaining first? Come into your first, third, what do you call it? Now leaning and stuff, push up from the chair. Have you tried that first with them? You are physios. Good stuff. Use it. We know all these things. I know we know all of these things. So these are poor manner handlings. Let's move forward because of time. So generally speaking, evidence-based practice, no pulling, no 2-person lifting, no 3-person or 4-person lifting. These are unsafe practices. These are unsafe practices. Let's move forward. Now, manner handlings. Ideally, I could have loved to spend time here as well, but because of time, I would just say NSP, our different physio group, we've got MRTB. We need good policies around these things. We need no lifting policy. We need educations. We need local policies where we work, where we all work. We need to advocate for this thing. We need training. We need to train MDT. We need them. We need to train those nursing staff. After patient, they've done surgery for a patient, the patient will be transferred from where they are to another surface. How do they move them? This is our job role. If we are doing these things, nobody can say open mouth and say physios are not. I don't know what physios are doing. It's not possible. Physios will be leading in all these things. Let's move forward. How do you risk assess patients? Risk assess. Before you use any equipment, you need to risk assess your patient. How do you risk assess patients? The first thing. Some people have come up with a lot of things, ties, elite, or whatever things. The thing is just, what do you really want to do? The task. Oh, I want to get them up from the bed. I want to get them up. They've had a fall. We want to get them up from the floor. We want to get them to the toilet. What is the task? Divine that task, first of all. Individual. Look at your patient. Look at your patient. Oh, yeah. Oh, look at your patient. Where have they got? Oh, they've got cognitive issues. They are distracted. They are agitated. They are confused. Think about all those things. You need to look at your patient first. Oh, they've got good core strength. They've got strength in their limbs. They've got this. They've got that. Think about that. The load is in terms of your patient and in terms of the equipment you want to use. That's what the load is saying. Yeah. You go to the ward. You are meeting an obese patient on a very small bed. What are you doing, physios? I've just spoken to the ward nurse, to the matron in charge. Something needs to be done. This is not very. I know. Yeah. Do we have any bariatric bed in the hospital we can support this woman with? It's not. Are we having those conversations? This is our job, bro. These are discussions we need to be having. So again, look at your patient. Look at the equipment. What equipment will be suitable for them? Is it going to be bariatric equipment? The chair they are sitting on, is that chair, is that okay for them? You are looking at all of these things. We have in our facilities, in the toilets we've got in the hospitals. If our patient need to use this toilet, do they have? It's not all patients that can stand, that can do sit to stand from a toilet height. From a toilet height. What have you said? What have we said to the management? What have we said to them? It's not everybody that can sit to stand from those things. So ADLs, looking at ADLs, looking at our input. These are some of our input. We are advising the management. We are speaking to the management of hospitals. They know we are doing our stuff. They know this is our domain. Anyways, environment. Look at the environment. I need to maneuver the equipment. I need to do this. Do we have sufficient space? Do they need appropriate lighting? If we are using that particular equipment for them at home. Your safe working bed height. The height of the bed. Oh, if you need to bring up the bed height, you need to be at your waist wrist. Lot again in our facilities, we are working with beds that are not even safe for us as a physios, or they are not even safe for other MDTs as well. So we need those training. We need to teach other people. We think they know them. So those researches that when I was preparing this slide, I tried to look at various researches that we've done in Nigeria regarding ergonomics and stuff. Honestly, we really have enough. I saw a lot from the north, from the west, from the south, and everywhere. But are we truly impacting some of the outcome of this research? Are we teaching other MDT? Oh yeah, the prevalence of clinical back pain in nursing staff. After your findings, do you actually have those trainings with them? These are domains we should be champion. This is our work. All right. So the other things you need to consider: staffing. Do you need 2 persons to be able to complete that transfer? Is it going to be 3? The equipment availability. Look at your settings. You can have one equipment, you may not be able to have one. You correlate which will be suitable for your patient. Is there any modification you can do for your patient? Think about those things. Communication, the queens you have to give to your patient. Oh, I want my patient to stand up. Evidence-based, what people prefer. They will say ready, steady, stand. If you need them to roll, ready, steady, roll. How do we queen them? Oh, we need them to do sit to stand now. How do you give them instructions? Oh, lean forward, nose over toes, all these things. They are very important. All right. So transferring and mobility, they are 2 different. Transfer is just getting from somebody from one service to another. Mobility is just now we are taking steps and we know all of these things. We don't have to waste time on them. Then again, when it comes to documentation, documenting like what needs to be documented. Oh, they need assistance of 3. They need assistance of 2 to mobilize. They need assistance of 2 to sit to stand. They need supervision. All of these things should be going into our documentations. So not just standing practice. Standing practice, you actually did that standing practice with assistance of 3, but you didn't put that in your notes. We need to be documenting these things appropriately. Even on the ward, if you are looking at nursing notes, you will also need to communicate to nursing. Oh, yeah, you people should start doing this. Document. Is it just one person that bring them, or is it family member? Is it one of them? All these things should be going into the notes because these things are important. If ideally somebody should be needing 2 persons to get them out of the bed, but they just written out of the bed, sit out in bed, and they are needing 2 persons, and you go there and you are struggling with them. Why are you doing this? They are unsafe practice, and you are putting your own health on the risk as well. All right, so because of time, these are some of these equipment here. So these are some of these equipment, just showing us what they have. All right, these are some of these equipment. So we need to start advocating for all these things in our facility. This is 2026. Nigeria is a very rich country, it's a big country. So it is the role of a physio now, physio, that can advocate for all of these things in our facility. The way we advocate for shortwave diathermy, the way we advocate for infrared that we've got. I know, yeah, the prices of this might be quite different, but advocating for these things are also very, very, very important in our facilities. Let's move forward. These are just collecting equipment and stuff. Yeah. So frame, we are familiar with all these things. Yeah. Let me start asking some questions here. Yeah. So we are familiar with everything. Yeah, of course, this is gutter frame. There are indications for that. We are familiar with everything. Yeah. Between elbow crutch or elbow crutches and auxiliary crutches, which do we prefer? I need response. And why? Like, which do we think ideally we should be using for our patients? This is a training on manual handling. So which do we think ideally we should be using for our patients? Let me just get a response from guys. Guys, what do you think?
Okay, between elbow and auxiliary
Elbow crutches
crutches.
and auxiliary crutches, yeah.
Well, it depends on the age of the patient and the muscle strength of the patient as well. So,
Okay.
but however, I would suggest we recommend as often than not elbow crutches than auxiliary crutches,
Okay.
especially for older adults. And because when you recommend auxiliary crutches, you know, the long-term use of it is not good, especially for the vessels below the armpits and all that. So, and then we should also factor in the patient's age and then the muscular strength, the upper limb strength of the patient.
Okay. Yeah. Thank you very much. Thank you very much for that response. Can I get a few more physios to speak on this? Like, because when I was making this slide as well, I did some little bit of work just to check some researches we have done if there is any like around elbow crutches and auxiliary crutches. Like, yeah. So what do we think? Yeah. Which do we think is the best ideally? Like, you want to give one of them for a patient now. Which do you think we should ideally be using in our facility? Yeah. And why? Yeah. Please response. Yeah, somebody has written it depends on the age, long, and how the patient what I say. Yeah. It depends on the age and how long the patient needs to. Yeah, the artillery for short use, elbow for longer use. Okay, elbow crutches to prevent compressions of vessels in the axilla. Okay. Yeah, go on. I think somebody wanted to speak. Go on, ma or sir. Which should we be using for our patient when it comes to indication now? Like, which should we be using for our patient? Because this is our work. This is our domain. And these are some discussion we can start having with, if you are in orthopedic, for instance, now, like, which should we be using here? Yeah, who is talking, please? Who is there? Because of time.
Hello, good evening.
Yeah, hello, good evening, sir.
Thank you very much for the lecture. I think the basis for comparison is small because their indications are actually different. Elbow crutches or farm crutches are usually used for long-term conditions, polio, any those acute flaccid paralysis, people with this pseudo hypertrophy. Long-term cases, auxiliary crutches is usually indicated for short-term fractures and things like that. So the consideration of arm strength and all, they are things that you can actually build on. Even if somebody needs forearm crutches and doesn't have arm strength, can build his arm strength because that is what you actually need. For instance, someone that has, I'm not giving him auxiliary crutches. Is what he needs is elbow crutches. So the indications are, I think, quite separate. Thank you.
Okay. Thank you very much. Yeah. Thank you very much.
Okay, so let me say something.
All right, ma.
Okay, so I think preferably elbow crutch is better because it will promote more normal efficient gait. So it's more like functional and also promotes more independence to a patient. And it can also progress patients in rehabilitation. I think so because we want patients to work independently at a long time. And also it's also for long-term use. And then lower risk of complications like the nerve compression the earlier speaker talked about. Thank you.
Hello, go on. I can hear you. Oh.
Okay, hello? I said I pointed out that it promotes more normal and efficient gaits and encourages independence and functional movement. Also, because you're considering patients to work independently at the long run, it also promotes better progression in rehabilitation.
Okay, thank you very much. Yeah. The reality is this. If we go on to check evidences around the use of these two, honestly speaking, when it comes to indications, their indications are very, very, very close. But if you look at, for instance, if you look at Nigeria for a whole, I think most of the time, what we give most of the time, auxiliary. Why are we not using it? If you look in terms of safety now, for instance, if you compare the safety, like elbow crutches is safer than, because if you are using elbow crutch, you are getting the patient to weight bear on their arm and this thing. But the other one, I know when we do our measurement, we do things, finger breadth or depending on whatever you want to measure it for. Still, your patient will still weight bear on the axilla. Or if they are not weight depending on the axilla, to posture, how about their posture? Do we consider that? Like stooping forward, all those things. And in terms of stair management, like getting to use one of them on the stairs, one is more safer, elbow crutches. So it could be something like, for instance, here in the West or UK or something, you might, in fact, since I've been here, I've never seen a patient using an auxiliary crutch. The practices here is just elbow crutches. So when I try to also take a look about some of the researches we've done at home, a lot of our researches are pointing towards elbow crutches. But the question is, why are in our facilities, why do we then tend to continue to give elbow crutch, auxiliary crutches? So we need to start paying attention to those things we are saying, not just for paper, for promotions and those things. Patient safety. One is more safer than the other. Why are we not doing the safer ones? So let's just think about some of these things. So I'll just move forward on these ones. We are familiar with this. I don't have to talk about this one because of time. So like I've mentioned, so on the ward as a physio, your role is checking patient AD health, how they are washing and dressing, how they are mobilizing to toilets, these are your job role. So checking patient AD health and documenting clearly how your patient is performing and formulating discharge plan. These are your job roles. All right, so I'm not going to talk about this one because of time. So let's come to this expanding hate here. I like to talk about these things because we need to start advocating, doing trainings, getting our CMDs, other healthcare facilities, doing a lot of trainings for them, because getting our government to be involved, like to start getting aware that we need all these things, just like we advocated for do sort with and all of these things. We need to start thinking about these things as well. So now, let's quickly run these things. What is this first one here? Depending on where you work, some people can call this one rotunda. Some people can call this one rotunda as well. They can call this one rota stand. Names, nomenclatures, they are not very important here. What matters? These two, practically, they function the same way. The comparison I'm going to make to simplify these things, this is Sarah Steady here. This one and these two here. Just imagine in your head now. Just think about this one, rotunda, Sarah Steady, ITAC, whatever you want to call them. These two are the same thing in your head. Just now, let's make that comparison with this one. These two comparison, let's compare with this one first of all. This is Sarah Steady I mentioned. If you look at this, I will try to keep this thing very simple. This one I've got a seat here. This one, these two has no seats. So when it comes to indications, what patient do you think can use this one? Like what patient group do you think we can use this one for? Like these two, what patient group? Oh, you are thinking that, oh yeah, maybe yeah, they've got good strength in their body. By the time they are able to achieve optimal standing, like good standing, they've got maybe with our assistance of one, the assistance of they've got good standing balance, and they are able to stand. They are able to tolerate standing for at least 30 seconds. Because these two equipment here, they are pivoting equipment. Let me just, sorry. These two equipment here, they are pivoting equipment. Pivoting is just, there is a part where you just hold, you rotate, and you use these things to get a patient to sit in the chair. What I'm saying is rotunda or rota stand or whatever name you want to call them, what this thing is being used for is just to get a patient, like just to transfer from one surface to another. Let's say from the bed to the chair, or from chair to the bed, or from the bed to wheelchair, whatever it is, just surface. Closely, it's just rotation. This thing will just turn, just pivot, just rotation and get patient to sit. Now, for you to rotate this equipment here, for safe manner handlings, you need to ensure that at least your patient can tolerate at least 30 seconds of good standing, 30 seconds. For you to rotate, for you to complete that manner handling. Not somebody that is bending down, that they are leaning heavily backwards. You are needing max assistance of you to support their standing balance. And even you, physio, that is holding them, your leg is already shaking. What are you doing? You are putting your own health at risk. And you are not doing things safely for your patient. But how about if that person just slip and fall? So if you've got that patient, they can stand well, yeah, with maybe assistance of 2 or 1, or they can even stand by themselves. And they're able to tolerate that standing balance, and you rotate this thing to get them on the next surface. That's fine. They need this thing. And again, if you compare this to our frame now, when will I think about this and not frame? That's another thing. I may want to think about these things not frame if, for instance, now somebody cannot step. Frame are literally for maybe mobility. Somebody cannot step. They cannot do stepping. I may start thinking about, oh, did they need rotunda? Or again, before I start thinking about this standing aid here, maybe this one, this rotunda and Sarah Steady, I also need to ensure that my patient have got sitting balance. Let's say I get them from line to sitting edge of bed and they are leaning backward, they are leaning sideways, they are not even sitting well. And you want to think about, yeah, let's bring them into standing. It's going to be too heavy. It's going to be heavy. It's going to be an unsafe transfer. Why not working on their, why not targeting their sitting balance, first of all, their dynamic starting balance, do all those reaching activities, do all those things, challenge their proprioceptions, challenge their visual cues to progress their sitting balance. Why not thinking about those things, first of all, before you start thinking about standing? So that the standing is not going to be too effortful for you to do and for your patient. So for you to think about rotunda, think about, yeah, they've got good sitting balance. Okay, by the time assistance of 2 or 1 that we just gave them, they're able to stand. They can maintain that standing balance for a while. Then we can rotate this thing to get them into the next phase. It's as simple as that. Sarah Steady. Oh yeah, they can stay. They cannot really come into good standing position, maybe because of their leg weakness. Oh, they've got weak cord. Because of their weak cord now, their knees are flexing. Their knees are bending. Or now they've got weak hamstring. They are leaning heavily backward. So they are needing somebody to stabilize them. So they cannot really tolerate that standing for few minutes. If you try them with rotunda, they will fall. And it's going to be on you. So now, why not getting them something they can sit on? By the time you bring them up, you put this perch there. and you can transfer them to the chair. Or if you need to, and again, this thing, yeah, unlike this one, this is just pivot. You cannot use this one to move patient from one point to another. It's just stand, rotate, sit. But this one, you can use this one to move patient short distance, maybe from the bed. Now they have stood up. You can use it to move from the bed and you move them to the toilet. They stand again, they sit on the toilet. If that makes sense to us. I'm just trying to simplify these things, their indication, because we need clear indication. This is our job, bro. Your job, bro. Your job, physio, ADLs, getting people functioning. If that makes sense. Hello, are we getting these things? Is it making sense, or I'm just, or what do we think? Hello?
It's making a lot of sense.
Okay, good. Can I get one more?
It's making sense.
Feedback. Hello, are we getting these things? So it might look quite abstract to us, but because so and
yes, it's making sense, sir.
All right. Thank you very much. Yeah, thanks. Yeah. So again, let me quickly repeat. For rotunda, you need somebody to be able to stand, optimal standing with minimum assistance, or they are fine with assistance. And again, when you stood them up, they're able to stand 30 seconds. Either you are giving them your standing, like your support for their standing balance to complete the rotations, that's fine. But for this one, somebody struggling, maybe they've got degenerative changes in their knee now, they cannot really come. And now they are in the hospital, it's really gone worse because now they are not eating, they are not feeding well. Now they've got infection, they got everything now. They cannot really tolerate that standing now. Their knee is now fully flexed. So get them a seat, patch them, let them sit and transfer them to the chair. How do you progress them? It is not progressing patients is not when you keep them in bed. When you are keeping them, you are making them to be prone to infections, integumentary degenerations, the conditioning and all these things. So you stood them to Sarah steady, then sit them out in chair. And again, physios, it is not like I mentioned, rehab is not when physio comes around again, alone. Again, on the ward, you can also say to the nursing staff, oh yeah, it will be grateful if we have some of this equipment. These are what nursing staff can also replicate. This equipment, these are ward equipment. These are ward equipment, not physio equipment. They are ward equipment. These are equipment that nurses can also be using for patients, to get patients to sit out for meals, for breakfast, for lunch. When their family comes around, the nursing staff can support them. This is physio job, training them to do those things. In an ideal environment, these are how things work. And why, yeah, if nurses are cracking on with these videos, you can now see, oh yeah, let's start progressing them. Yeah, let's progress them. Let's do some sit to stand. Nurses will not be doing that. Let's do like 3, 4, 5 sit to stand to rotunda or to Sarah steady to strengthen their lower limb. Functions. That sit to stand is 100% more than doing your static cord for somebody in bed. If they can stand, and you are thinking about doing static cord in bed, what are you doing? A patient can stand. You are not bringing them to standing. You are doing static cord in bed. You sit to stand reps. Get their reps. Get them out. Let them sit out. This is far, far important than the stuff you are doing with them in bed. All right. If that makes sense, let's crack on then. So what of this one here? If you look at your screen, what of this one? What's this thing? This is standing hoist. We've got 2 forms of hoist. There is one that is full hoisting. I'm going to show you the picture. And this one here, this is a standing hoist. So when do we need this one? Imagine we've got a patient, they are bariatric, or just normal patients now, like normal BMI itself. We are struggling to get them to sit to stand. This thing I've got a remote. By the time you put the sling and everything, just press the remote. This thing will start lifting patient up. These are very safe rehab, safe things, lovely things. Your patient will going to like these. Even physio, you as a person, you will love using some of these things for patients. Let's start advocating for these things. You start pressing this thing will come up. Your patient will start coming to standing. You can use that, your rehab, to do multiple sit to stand, progress your patient, get your patient to sit. It's got a wheel. You can use this thing to transfer patient to another position as well. Very simple thing. Very simple. Rather than 5, 7 person, yeah, they cannot do sit to stand from chair. We now need 5-7 person to live there. What are we doing? Come on, this is 2026. All right. So what about this one here? What about this one here? This is, let me repeat the name again. These are rotunda. This is Sarah Steady. This is standing hoist. This one here, these two here, these are Mo lift. This Mo lift, they work exactly like rotunda here. And the difference is just Mo lift can also come with this thing, a belt, that you can further use. Maybe two of you, one on this side, the other person on that side, rather than you pulling up patient to stand. I have mentioned today, no pulling. It's wrong. It's a very poor manner handling. So rather than doing that, you can support these things, put it on their underneath, their glutes. You are supporting them. So the difference between this and the rotunda is just the gait belt. And sometimes you can, even without the gate, you can use just normal rotunda without the gate, get your patient out in bed. Again, for you to use this one, to use more lift as well without the belt, somebody can stand for a few minutes, they can tolerate that standing balance for a while, for you to turn them to sit in it. How about this one at the side? This is Atlas frame. If you are working in ITU physios, patients that are very, very deep conditions, they have been in bed because of their infection they have, because of they have been ventilated and sedated and stuff. You might be needing these things to progress your patients for rehabilitations, because these patients, they need to weight bear on hand, they need to weight bear on their forearm and everything to further support them, to progress them into standing, to progress them into mobility. Those kind of things. These are equipment we can afford in Nigeria. These are equipment we can all afford in Nigeria, honestly. So yeah, how about this one here? Because of time, I'm just trying to, because of time, so I will not be bringing clinical cases to you because of time. So what about this one here? This is still table. I'm sure we've seen this one a lot. This table, yeah. You can have patients struggling with blood pressure. You can have patients that are struggling to come into standing. They cannot even stand to any of these things. You can use tilt table. You start progressing in 30 degrees, 60 degrees, these things. Tilt table to progress them, and you are monitoring their blood pressure. If they've got postural drop or something, or you are even using that not because of blood pressure now. You are even, maybe they've got SCI, whatever thing they've got. You even use this to reinforce somebody with bearing, with bear. That person to start doing early weight bear, to strengthen their bones, to strengthen their muscles, to prevent further deconditioning and stuff. Let's move forward because of time. Let me repeat, these are rotunda. You need these things to stand. Your patient must be able to stand well, tolerate good standing balance. For stoop standing, you might think about using Sarah Steady to patch them. And then this is standing hoist. You can think about this one if your patient is maybe struggling to do sit to stand from anywhere. And again, for somebody to use, if you look at this one here, rotunda and Sarah Steady, your patients can also support, pull up. They can pull themselves out using the upper limb. Yeah, if the patient have good upper body strength, it's going to make your work very easy. As opposed to frame. Do you want your patient to be pulling up on frame? Frame have not got a break, but by the time they pull up, they will tilt backward. That's a poor manner handling. And if you are not getting them to pull up, you are getting them to push. Do they really have good strength in their leg? So it's all about you thinking about what is the indication here. So that's it. If that makes sense, we crack on. So, and again, let me say these general guidelines. If you are working on vascular ward and you've got an amputee patient, generally speaking, worldwide evidence-based practice, if they are vascular amputees, like the reason for the amputation is vascular. Let's say they've got above knee or below knee, these standing aids are not generally recommended for them. Because generally speaking, you don't want, and these are something we do, honestly. These are unsafe practices that we are not supposed to be doing. Giving an amputee patient, giving them vascular amputees, giving them a frame to be open around. Vascular. You might just let's clinically reason these things. For somebody to have vascular like they've got diabetes, they've got peripheral, vascular disease, and that disease progressed to the extent that they lost their leg. What that means is there is another chance that they can also lose the second leg. So, and they are not open on that their good leg. What are they doing? The chance is there that they can also damage the other leg. And aside from that, how about the risk? There is risk of falling. We should be, that is why I mentioned the risk assessing patient. For every equipment we are giving to a patient as a physio, we need a thorough risk assessment. Consider their safety and all of those things, if that makes sense. So, all right, I won't talk about this. So this, I deliberately popped this slide there so that we guys can read through and further understand some of these things. Yeah, I'm going to send this slide to us. So this is hoist. When do we think about full hoisting? Somebody in bed. Remember that lady from the slide I brought initially that was trying to lift somebody in bed, lift them out of the bed, like manually lifting them out of the bed. Imagine you've got a patient on your ward. These patients cannot even roll in bed. They cannot even roll. And again, physios have come, lovely physios, very excellent physios. They've tried to see them at the edge of bed, and this patient is just too very, very poor. They've got a very, very poor physiological or physical reserve at the moment. They cannot even tolerate sitting. They are just floppy. You cannot. Of course, what do we do again, physio? You return them back to bed. So do you now want to keep that lady in bed? Do you want to keep them in bed and you will now keep going and stay there racing in bed, excuse? What are you doing? Is that what evidence is? Is that what evidence-based support? No. The idea things is, think about this thing. Oh yeah, you can get them out. Equipment like this, hoist. You can use this full hoisting. Roll them side to side, pull the sling, and we can use the hoist to get them to sit in the chair. And once they're out in the chair, wow, you have established that equipment is safe for that patient. Yeah, nurses on the ward, you can train them to continue that. And why you come next day, second day, third day, is that the same equipment? Because this hoist is a passive transfer. Let me just say that, passive transfer. Your patient might not even need to do anything. You might just do everything for them, lift them up and put them in the chair. Yeah, putting them in the chair. What are you doing? Physios, we know all these things. Yeah, they are building their sitting tolerance, their core strength. They've got sitting balance. Remember, now we are putting them. And again, remember, what kind of chair do you need to put them in? Do we somebody that is very, very floppy, cannot even tolerate sitting? Do you still now want to put them in a standard chair? You need a tilting space chair, a chair that can sit backward, where they can relax. And you keep them, you can tell the nursing staff, keep them there for 2 hours, 3 hours. What is the goal for you doing that? Progressing their core strength. This is rehabilitation in acute hospital. This is rehab in hospital. If we have all of these things, we should be doing them. We should get all of these things and we start doing these things. If that makes sense. So hoist is just passive transfer. Let's say you've done that, you get a patient to sit in chair, they can tolerate that, they can tolerate. And again, let me say this. Not all patients in bed can also tolerate this thing because you are lifting them up. Some people can be very panicked, or remember somebody that is very confused, that is agitating now. By the time you lift them up, this is part of your rule. Before you start using this thing, risk assess that patient. Oh, can they tolerate this man that is very confused now? I'm not sure he can tolerate it. Think about another thing you can do for them. Manual risk assess your patient before you use any particular equipment with them, if that makes sense. All right. So think about those things. So now, day 1, day 2, you get them. They are already sitting in chair. The nursing staff can crack on with this one. What else do you do as a physio? Oh yeah, we can now continue our sitting edge of bed balance. Let's do reaching and stuff. Let's do our exercises to progress your sitting balance. Let's start progressing to the standing. Standing, do they need Sarah steady? You think that they need rotunda? You start, now they are now in chair. Do they need full what do you call it? Standing hoist? You start thinking about those things, if that makes sense. Guys, I will stay there. Is it making sense? Or I'm just saying loads of abstract things. What do we think? Hello? Hello?
Well, we are here. It's making sense.
Yeah. All right. Thank you very much. Yeah. Let's move forward. So I'm not gonna. Like I mentioned, all these slides are just there for us to read through, to see some of those things, to further get the clinical reasons. I was talking the other time about moving patients from one bed to another, from one table to another. That's sliding. Physios, we should be championing these. Get those nurses, those doctors, get them, teach them all these things. Stop lifting or pulling patients. This is our job. You are teaching them your own, some of those things they need to be doing. backsliding, all those things. So they are there. They are banana board. I know we know these ones. We know this. But how, do we even truly have? Do we have this? I know some parties that don't even have as simple as this one. These are things we need to improve. Now you've got a patient. They cannot do. They've got good upper body strength. They've got good sitting balance, but they cannot tolerate standing. Maybe because of their post. This is acute hospital. They cannot. You need to clinically reason things. They cannot tolerate standing. Anytime they come to that, their blood pressure will just drop. They feel dizzy and back again in bed. So you want, and do you think leaving them in bed is going to make their blood pressure, is going to make it get to bed better? No. What do you want to think? Oh, now they cannot stand. It's not every patient that can stand. If you are in acute hospital, you understand what I'm saying. It's not a patient, not because no strength now, no strength point of view now. Physio, what do you want to think? We discussed blood the other time. Now observations. What do you want to do? They are postural, you give them abdominal binder, you give them test stocking or whatever you want to do to them. The thing is not still working. You've spoken to the medical, they've changed their medication, everything is not working. So are you going to leave them in bed and run away? No. Think about getting these people out of bed. It could be like maybe we just do people's transfer to chair. It's not everybody. It is not everybody. Think about, okay, now they cannot do pivot, or they cannot do low lateral transfer, or let's try banana board. Even before we try all this, what I normally do, if I get you to the edge of bed, I can just ask you to do as simple as do button lift at the edge of bed, just to check if you are able to clear your glutes. If you are able to clear your glutes, I can say, just bring the wheelchair closer. Let's do some transfer. Remove the armrest. Let's do some lateral, whatever I want to do. If you are struggling, say, let's pop banana board. Let's pop banana board to make it more easy to reduce friction. Pop like a slide sheet or whatever on it, or a pillowcase or something to make it more easy for your patient. Let them use their upper body strength they've got. Let them start sitting now. It could even be, I can tell you, I can even tell you that doing that sitting, getting them to start sitting out in chair, you have educated them to start drinking a lot of fluid, to be tapping their foot and their toes on the floor. And that could be that, as simple as that thing is, it could actually be what could make their blood pressure. What could actually make their blood pressure to get better in the long run. And again, if we are not able to bring them into standing position in the acute hospital, that's fine. What do you want to do? Equipment before they go home. Equipment. Baba, now that we are struggling to do this, have that equipment, because you know that they are going home. They are not going to stay in the hospital forever. Have that conversation with them. We need to buy a wheelchair now. We need to buy banana. If they don't have wheelchair, ask them, what kind of chair do you have at home? What kind of chair? If you can ask, these are some of the rules of the OTs. Tell them if we can design hospital like a photo, like just to get the height of chair of somebody, the height of their bed, this thing. We can send them to them. You can have the family member to go and take the measurement. Or OT can, if it's not comfortable for us to do home visit, to go and assess their home. This is our job. This is our job. We can send them. They can snap. This is they can snap. This is modern age. They can snap their home, their chair, the kind of toilet they've got at home. They can snap those now. We can review. Yeah, will this thing be safe for this patient? What equipment do we need? Them all those kind of things. So let's start thinking about these things. So yeah, wheelchair. I know we are familiar with wheelchair, but I've got a question to ask us here. What is these things here? This is anti-tipper, right? When will you consider giving a patient, you have given a wheelchair to your patient, when will you consider giving anti-tipper for your patient? Just 2 persons. Guys, let's speak. When will you consider giving your patient anti-tipper on their wheelchair? Because this is something, again, that we just give wheelchair, we don't even care. When do we consider giving these things anti-tipper? And this is cushion again. Physios, we just give wheelchair. Somebody have got spinal cord injury. You know already they've got a poor prognosis, they are likely to be in chair for the rest of their life. Are we giving them pressure cushions? Because we know that wheelchair is going to be a sitting aid for them. It's going to be a transferring aid for them, a mobility aid for them. Are we giving them cushions? And depending, what do we check? If you need to give a particular cushion for a patient, 2 inches, 4 inches, what are we checking? And we have some people to speak about this thing. This is just clinical. We are physios, we are professional, well trained. Can we open mic and just speak about this thing? When do you give anti-tipper for a patient? They are different. This thing comes with different height, 2 inches, 4 inches, all those things, 6 inches. So like, what do we need to consider to give these things for our patients? And how do we treat them pressure relieving these things? Yeah. Can we just talk about these things? Speak, let me learn too. We are here for learning. Yeah. Open mic. Hello. Hello, guys. Hello. Oh, yeah. All right.
So let me try something.
Yeah, go on.
Okay, you talked about the anticipa. When do we consider giving that?
Yeah.
So when we have someone that maybe a new wheelchair user or a patient that has a weak trunk, that we're concerned that the patient might suddenly trip backwards
Okay.
unintentionally. So we can give that just
Okay.
to prevent any near fall about that. So it could vary from any other conditions, maybe spinal cord injured patients or elderly patients that are frail at the same time.
How about the pressure cushion part? This one, like they come with different sizes, 2, 4 inches, 6 different things. Like generally, like how do we decide? Oh yeah, you're gonna be needing 4, you're gonna be needing these things. How do we decide for our patients? Yeah, who is helping us? Yeah, the chat box is there. Pop the response. Yeah, and you can open your mic, speak up. Yeah. Yeah, so I feel like that Antitypa is just to combat the center of gravity of like just to counterbalance the weight. Imagine if you've got an obese patient, for instance, now. Oh, they might likely tip backward. What do you want to do? You are getting somebody to further, you are getting something to further stabilize the wheelchair. It's just clinical reasoning. These are not big things. These are not big things. These are things we know generally. Oh, for size 2, size 4. You've got somebody that is very big. You know, when they sit, just imagine the guy is very in a patient that I have just like let's say for instance now my BMI is just very low. If I sit on a chair, there might not even be impact on that chair. And if my BMI is very very big, if I sit on a chair, you're gonna see there's gonna be a compression on the chair. So if I want to give you size 4, size this thing pressure cushions, I need to look at your BMI to make that decision for you. It can make sense. It's as simple as that. Okay. All right. Because of time, toileting equipment. Yeah. This is another thing. Yeah. Toileting equipment. These are simple things that, what do we call them in Nigeria? These people we can make these things locally. Freestanding toilet frame, all these things, we can make them locally. But are we checking these things in our hospital for a patient? You've got a post-op patient, they've just done knee replacement, hip replacement. You are sending them home. You know this patient, they are going home, they will be using the toilet. Have you checked their toilet transfer in the hospital first? Again, our toilet in the hospital, is it even, is it well hygienic for us to be going there to be trying patients on their transfers? These are things we need to discuss with the management of our hospitals. These are things, because these are part of our job, bro. ADLs on the ward. Oh yeah, ask your patients what kind of toilet do they have at home. They've got this kind of toilet at home. Yeah. And again, if this toilet that we cannot replicate because of our situation in Nigeria, think about clinically reason, ask them to bring photo, how it looks like, or describe. Clinically reason that what equipment, or I give them another equipment that can mitigate them going to be using that toilet, because that toilet is currently at risk. They can fall in that toilet at the moment. Let's think about all these things. Are we doing these things? Are we checking them? So now let's talk about this. The first one here, this is freestanding toilet frame. It's just like a frame, normal regular frame. This is just toilet frame, yeah. So when do you give this one to a patient? This is a raised toilet seat. This one, you just put this one on the toilet. It's going to make the height, it's going to make it taller. And this one here is a Mowbray. These are Mowbray. So Mowbray is just, you are combining the frame and the seat. The two together will make your Mowbray. Now, the question is, because generally, I'm sorry to say this, generally what we see people asking different physio group. He say, hey, do you have electrode? Who has this? Why are we not asking these things, some of these things for our patients? We need to be asking ourselves these very good questions. Oftentimes, what you see people asking of infrared. Well, do you know anybody that said infrared? I'm not saying infrared, but why are we not asking ADL's equipment for our patients? Why? Why? We need to start asking ourselves those kind of questions, and we need to be making those things because ADS function. Our attention should be on functions. Think about it. Let me just say this. It's just by the way, just think about it. Oh, focusing on range of motion is what we are focusing on patient. Ideally, you as a physio, you as a person too, if you need to mobilize, do you really need, if you need to ambulate, do you really need that your hip to come into your chest before you walk? You just need few range, 10, 20, about 30 degrees or so to mobilize, and you are fine. So function is really, really very important. But yeah, between your range of motion, do your strength, but tie everything back to function. Think about what equipment would that particular patient need based on how they are presenting. If you look at the concept of ICF model, impairment, activity participation restriction, activity limitation, everything, our physios will cover everything, not just impairment, not just range of motion, not just pain, not just this thing. Cover activity, look into their ADL, their washing and dressing, grooming, toileting, these things on Battelle index. Try to do all of those things. This is physio. And when you are with patient in acute hospital, this is what you need to be checking. Check their bed because they are going home, they'll be sleeping in bed. You check their toilet, how they are going. If they are saying they are living in upstairs, ask them what kind of step, how many steps. You give our facilities, try them on stairs, do stair assessment. Are we doing all these things with our patient before we discharge them? Let's think about all of these things. All right. So when do you give freestanding toilet frame for a patient? Clinical reasoning time now. Guys, we are running out of time. Clinical reasoning time. When do you give freestanding toilet frame? When do you give this one? And when do you give raised toilet? Just 3 persons, and we move on. We move on to question, and we are rounding off gradually. Yeah, guys, what do we think? Please open mic, pop the response in the chat box. Open mic. Guys. So when do we give just normal frame for a patient to use in their toilet? Because we need to ensure we are giving the appropriate equipment. When do you give this seat? And when do you give the combination of the seat and the frame together for your patient? Yeah, are we there? Hello? Yeah. PT Ashley has mentioned when they need assistance to stand from the sitting with their hand, we give freestanding toilet frame. Good stuff, lovely stuff. Yeah, good stuff. Pop the response in the chat box, raise your hands, open your mic, talk. This is just clinical reasoning. Yeah. Good, lovely stuff. Yeah. Who is there? Who is speaking? When do you just give raised seat? Because we need to be clear. Because all these things come with price tag. Patient is going to buy these things. Our government do not cover these things. Even if we have them in the hospital, they will just be for assessment in the hospital. We're not going to give it to patient to go and be using at home. So we need to be very clear that this one that I'm giving to you is going to help you. Yeah. All right. Let's read again. Yeah. When they can't ambulate hall, PT Kido, I always struggle with this name. I don't know. I'm sorry. They can't ambulate hall to the way to the toilet. Okay. Okay. PT Adeyeye has written the combination should be appropriate for hip replacement surgeries. Good stuff. Lovely stuff. Yeah. Lovely stuff. Yeah. They need support in the seat to stand motions. Which of them? Yeah, that's good. Yeah, good stuff. I love that. Yeah. So now, clear indication now. Let's look at it in terms of stability because of time. Which is more stable here? Because we need to be very, very clear. This is our job. We need to know this thing clearly. Which is very, very stable here? keep popping the response in the chat box. That's fine. It is very stable here. This one, the Mowbray, the one that has the seat and the one that have the frame. This one here. There is another name for Sakadi or whatever. Frame is frame. Mowbray is Mowbray. Don't worry about nomenclature. Yeah, the one with the seat and the one with the frame is the most stable, right? Now, if let's say I've got a patient, I'm really, really very worried about their stability. Oh, they are really very unpredictable. They can, and again, they've got a weak, let's say they've got a weak leg. They've really got a weak leg, and I'm very, very worried about their stability. I can start thinking about the one that have the frame and the one that have a seat. And again, and this person, they've got a good strength in their hand as well, so they can push up. They can push up. And again, the seat again is going to help them to easily come into standing position because the height is a bit elevated than normal toilet. I think the height of normal toilet, this one you've seen here, normal is, I think it's around 16 inches. So by the time you give them, this one is around 2 inches. By the time you give them that 2 inches, you're already making it 18 inches. Yeah, 18 inches, fine. Yeah. You can think about that, give them that one. Or you've got somebody, they've just done a hip replacement surgery, for instance, or not hip replacement, or you've got somebody now, they maybe they've got a degenerative changes in their knees, they've got a weak knee, they are struggling. You of course you need to be assessing your patient before you give them any equipment, and even after you give them equipment, still assess your patient with that equipment if that is suitable for them. Don't just give equipment to a patient and say go home. No, not ideal. So ideally, we expect all these things to be in our facility. Physios, you go with these things, you assess your patient with, you say, yeah, this is most suitable for them, and you ask them to buy it, or you educate them about it. All right. So now, for a seat, let's say somebody actually struggling with seat to stand. Like maybe like few inches to stand. They can actually come into standing. They can actually come into standing, but you feel like, oh, because they got a reduced range in their hip or in their knee, that is actually what is affecting them. But they are still coming into standing. But it's just a little bit effortful for them. I can give them just this one. Just the seat alone. Or they've got hip replacement surgery, knee surgeries. Because of pain. Or maybe they generally, knowledge has even gone beyond all of these restrictions or these things. But again, if that is what they have said, the doctor, orthopedic doctor, don't flex on it to this, don't do this, don't do that. Okay, you can think about give them that seat. Make their journey, make their transfer more easy for them. Think about that. And again, you want to give normal frame for patients now. Just normal frame now. Think about these things. That patient can actually stand up from normal toilet, regular toilet. But when they come into standing, they start feeling wobbly. They start feeling, maybe they are feeling unsteady. They need to immediately hold on to something and give them. There are a lot of examples you can start thinking about. I'm just giving you some background about these things. And again, before we give any of these things to our patient, you need to ensure that your patient can walk to the toilet. It was what PT Chidoke written that make me to remember that. You don't just give this to a patient. Your patient is needing assistance to transfer to the chair from the bed, and you are giving them this. What are you doing? You are wasting their money. You are helping them to be wasting their money. Why not think about what you can give them at the bedside, first of all, to aid their toileting, like commode. Let me see if I've got the picture here. Give them commode. Where is it? Let me just go. Yeah, give them commode, the bedside commode. Give them commode. So now I can think about commode as, oh yeah, something I can just give to my patient. This patient is just, they need toileting, they need everything. They've got spinal cord injury, they've got this thing. They cannot go and use the toilet on their own. Family need to be doing the washing and dressing with them. Why not asking them to buy these things? Patient can just sit on it, on the chair. Or even patient is just needing minimal assistance to transfer to the commode. Why not just asking them to buy these things to make it more easy for them to do their toileting? Are we having those kind of discussion with our patients? Or do we just think they cannot buy? We've got people that may not be able to afford it. And again, we still have people that can actually afford these things. In fact, not just about they've got limited mobility, they are bedbound or something. How about patients? They've been having repeated falls. or they cannot tolerate standing, or they cannot, because of their reduced mobility, or because of their fatigue or dizziness or anything, they cannot walk down to the toilet. However, if you give them this commode, to be using this commode at the bedside, just to reduce that urge of rushing to the toilet. While rushing, they can fall along the way. These are clinical, this is our job. This is our job, yeah. What are you doing? You are helping them to save future money. That if they fall, they will have to come to the hospital, they need to do surgeries of this. You are just saving them. You are saving them. You are teaching them how to pace. You've got somebody that is very short of breath. Are you thinking about this equipment for them? Think about that. In fact, there is another thing here. This is the one here. If you look here at your screen, this one here I've got a wheel. This one I've not got a wheel. The one with the wheel, when do you give the one with the wheel? When do you give the one that does not have the wheel? And again, this one without the wheel can also go over the toilet. Just like you've got that seat, you've got that mobile. It's all about clinical reasoning. If I give my patient, let's say for instance, now for night use, I can say, yeah, if you use wheel commode bedside, your family can also wheel you down. That can also go over the toilet. You can, if you need to even do it in the toilet, rather than me needing to empty the commode for you. So all those kind of things, these are just clinical. Look at your patient, look at their presentation, look at the financial aspect of it, and give them that professional advice. And again, you cannot imagine somebody that cannot even walk down to the toilet. If you give them, before you give them this static commode, ensure they live. Of course, in Nigeria, we live communal life anyways. There must be somebody there that is always ready, that will also be ready to empty the commode for them whenever they use the commode because of infections. Somebody must be there because they cannot walk down to go and empty the commode on their own. Clinically reason, just factor in some of these things, all these things, before you make the decision for your patient. This is our job. This is what we need to be. We can train staff. We can train staff for these things. Imagine in the hospitals, the way our hospital do our hospital have some of these equipment? Our poorly peoples on the bed, that they are opening their bowels on the bed in the hospital. How are we supporting them, like protecting their dignities and making things life comfortable for them? This is our job. This is what we need to be doing. This is what we need to educate our management in the hospitals to get some of this equipment to further make life more better and more dignified for our people. Anyone can be poorly at any point in their lifetime. No one will like to be treated anyhow. Nigeria is rich enough to make life more easy and more convenient for its citizens, for our citizens. So let's start thinking about some of these things. This is our job. This is our job. I cannot overemphasize that. That urine bottles as well. You've got urine bottle. You've got somebody, they live upstairs, and this elderly patient, they need to come down. They love to go downstairs. Or you have a patient, so you can give them urine bottle. Or you have a patient that maybe they are bedbound at the moment. They will be open. They will do number one. They will do number two. This is a part of life. And they cannot walk down to the bed. They cannot walk down to the toilet. They cannot walk down to the toilet. This thing does not have to be they buy like it look like. So it could just be normal bottle. Give them, educate family. Get bottle for them to do these things rather than needing to be doing everything on bed. They already know the urge will come. We need to be educating them, the family members, about it. This is bedpan for patients that are bedbound. We can get this thing to further make life comfortable. We can ask family to get similar things or things like that, further make life more comfortable for them. All right. Of course, equipment to use in the shower, in the bathroom as well. This is daily life, because you are checking people's daily life. They do their shower, they need to use the toilet and everything. You can ask them, get a chair in the shower, sit, do your washing and dressing on the chair. Rather than needing to stand and you have a fall, you are back in the hospital, all those kind of things. These are things we need to be checking before we let go our patient in the hospital. Somebody have come, they've got a stroke. They came to the hospital, they have an acute stroke, they are very poorly, they have hemiparetic or left weakness or whatever things. They are struggling with standing balance. Have you begin to talk them through some of these equipment? All those things we need to check. You need to check and advise them appropriately. I know the financial part of it, but at the same time, we also need to be having these discussions with our patients. Just look at the risk. What is likely to happen if they don't do this? If they do this, what is likely to happen? Give them that professional advice. All right. Let me move forward. I think I will just go straight now to there are a lot of them, people that cannot read their back. These are OT stuff. Just read this one. Yeah, I have to talk about this one, a slide sheet. What is in slide sheet that we cannot even find on our ward in Nigeria? This is embarrassing. Slide sheet is just better way. Let's say somebody is slumped in bed now. A patient is slumped in bed. You want to get them upright in bed. Just pop the slide sheet and you get your patient upright. Slide sheet, what is in this one that we cannot get on our ward? Train the staff, train the nursing staff, train everybody. If patient that is slumped, for appropriate positioning in bed. Positioning is one of our key physio domain. It's one of our underdeveloped things. Slide sheet. Or you start patient at the edge of the bed, they've got good pop sitting balance, you are done with your bed exercise, you are done with your edge of bed exercises you are doing with them, and you know that if you need to get the patient upright in bed, you need to get your patient back in bed. You need to get your patient back in bed and position them upright. You can pop the slide sheet. Pop the slide sheet underneath. Get them back on the slide sheet. Use the slide sheet to reposition them upright. These are practical things. These are things that I cannot start teaching how you do that, but these are it's just this teaching is just creating an awareness. This is our job. Dressing aids, equipment aids. I'll just move away from all of these ones. No, there are a lot of them. All these things are self-explanatory. By the time I send this slide, if you look through, I'm sure we will be able to grab some of these things. Yeah. So scenarios. Please, I need participation here. And I also think that the organizer, they have mentioned to me that there are going to be a short, maybe, I don't know if we already have the, what's it called now? I'm finishing up here after this one. So if you already have the Google form, so we can just pop that in the Google form. I don't know if that is available now, but patient one, patient cannot stand and has poor sitting balance. They are weak, they are leaning backward and forward in sitting. And how do you the question is, how do you mobilize them out of bed? Physios, let's just answer this question and we'll stop for today. Case one, you've got a patient, they cannot stand. You've tried to sit them at the edge of the bed, but they've got a very poor sitting balance. So they've got a weak cord, they are leaning sideways in the bed. So how do you mobilize this patient out of bed? Who is answering this question for us? Like what equipment, for what I just discussed, what equipment are you thinking? Because this patient cannot, they have poor sitting balance. They have poor sitting balance at the moment. And this patient again, they cannot stand. So what equipment are you thinking about? Are you going to just return them back to bed and you come next day, you return them, or you now leave them in bed and you're not doing SQC, SLR, this thing in bed? What are you doing? What are we thinking about it? What are we going to do for this patient? Who is helping us? Please, let's get a response to this thing so that we can end.
Hello.
Hello, sir.
I'll use this. Use the slide sheet that you just recommended.
Okay. Yeah, you use a slide sheet, good stuff, to get them back in bed. Now that you have got them to the edge of the bed, you can use slide sheet to get them more upright in bed. Good stuff. However, if we need to get them out of the bed now, because the safe practice, the ideal practice we should be thinking about is getting this man or getting this lady to sit in the chair, because she's got good poor sitting balance. So we need that to be sitting in chair. That is the safe practice here. That is evidence-based. That is your clinical, should be your clinical reasoning now. So what do we do here? That is our clinical reasoning. So what do we do here? Yeah, slide sheets, thank you. Yeah, back in bed. Yeah. Somebody said, PT Deborah said for case one, slide sheet and standing hoist. Okay, good stuff. Yeah. PT Ashley said transfer with hoist. Yeah. PT Yusuf said the tilt bed can be used. The tilt bed can be used with strap. PT Olamide with out of bed. Yeah, getting them out of bed. You can use hoist to wheel the chair. Okay, yeah, good stuff. Yeah, good stuff. Yeah, good stuff. I'm happy with all of these responses. Let's pop them up. Yeah, Sarah Steady. Yeah, PT Adeyeye. Yeah. Good. Pop them out. Yeah. We use a hoist for transfer, slide sheet for bed mobility, good stuff, and a supported wheelchair or chair due to poor sitting balance. Good stuff. That's from PT Ngozi. Good stuff. Yeah. Lovely, lovely, lovely. Keep popping them up. What are you going to do? This is our patient. This is our lady. Yeah. She's got poor, very, very poor sitting balance. She cannot tolerate sitting balance. So are we just going to keep her in bed to get pressure sore, to get DVT, to get chest infections and die? No, we're not going to do that. We are lovely physios. So what are we going to do here? What are we going to do for this lady? What are we going to do? Yeah. Good response. Thank you, guys. What I'm going to do is, yeah, slide sheet for bed mobility if I need to return them. Maybe they are now fatigued at the edge of the bed now. We cannot progress the rehab that day. Yeah, get them into lying back on the slide sheet. We use slide sheet to slide them up. Safe transfer, very safe technique. Bring the bed height to your safe working height, your waist or something, safe working height. The slide sheet, slide them up, you position them upright in bed. Keep them upright. Tell the nursing style, yeah, regular turning in bed. Family members at the bedside, regular turning in bed, because these are what you need for that same sitting balance. Sit them up. If you got that bed in the hospital, of course, these are things we should be advocating for. Sit them up, upright in bed. Keep them in that nice and very good, safe sitting position in bed. Build that sitting tolerance in bed as well. Good. But now I come the second day. I already know I have established from my first section that they got poor sitting balance. And now I want to start progressing their sitting balance. I will now start, bed exercise. Yeah, I can do my bed exercise. That's fine. But I need to think forward, progress them forward. Think about that hoist, that equipment that you can use to lift your patient up and put them somewhere in the chair. Then what kind of chair are you clinically reasoning for your patient? Two things, space. That chair that can tilt backward, that recliner chair, that rear axilla chair that can tilt your patient backward, that can offload their trunk muscles a bit, that can, for them to be able to tolerate that sittings. And again, while they are sitting, you are building their sitting tolerance. Again, you are helping them to prevent DVTs, you are helping them to prevent chest infections. If they need to cough, they can easily cough and clear their air with this. This is why they need to be out of bed. This is why if the exercises you are doing in bed with them is the wrong one you are doing. Because while they are in that good sitting balance, good sitting position, they can cough, they can clear the airway, good stuff. You have answered, you have turned your patient. Then from there, you have established that, yeah, that is safe, the patient can tolerate. You tell the nurse after that transfer, you tell the nurse, oh yeah, please keep them, because you might not be able to return back to that ward. You got some other patients elsewhere that you need to be seen. The nurses will be able to return them back to them. Mobilizing patients, getting patients up. It's also part of the job role. Even in Nigeria, I've gone through some of their stuff. So the nursing staff, you should be able to train the nursing staff, the junior nurses and everything, should be able to return that patient with that same equipment. Give them how many persons? 2 persons. Of course, for any of those, I didn't mention that you need at least 2 persons for safe transfers to complete those transfers with your patient. If they are needing more than that, maybe 3 persons for safety and anything, tell them 3 persons, 3. And we need mobility board, physio, this is our job. Something like a board around the patient bedside. This is Acute hospital. Put it there, mobility. These are something we need. This is why we need trainings. I don't know, there are some facilities that have, if you don't have it in your facility, look around that. This is service development. Get those trainings, teach everyone. Let's get that small board. If anything the doctor wants to communicate, they can put it in that board. That's very important. That everybody must be doing for that patient. If there is anything you feel you want to communicate, put it in that board. Oh, voice transfer assistance of 2, assistance of 3. Everybody knows. You have already trained them. They've had the training. You are doing the regular renewal of that training for them every year. They already know that. So the nurses should be able to support them back in bed. Now, day 5, day whatever now, I want to continue my rehab. The nurses can crack on, getting them out of bed for regular meals, to sit out 2 hours, 3 hours every day. I can now start doing my own rehab. Yeah, let's start them. Continue your sitting balance education, re-education, reaching, trunk retraining, this thing. Let's have leg strengthening exercise, all those things. Let's start, let's progress into sit to stand, all those kind of things. Progress with that. It's as simple as that. But that initial, because it is not everybody in Acute hospital that will be able to stand to the frame, that will be able to use those our back slab or whatever you will call them. We need to start moving away from those things now. Start thinking, thinking, acutely unwell, patients that are acutely unwell. It is not everybody. All right. Case 2, what are you going to use, guys? Good sitting balance, good sitting and standing balance, but they cannot step. And they are, because of this, they cannot step. So they've been in bed for a while. So what are you going to do, physios? So you're going to leave them in bed as well? They cannot step. Maybe it could even be maybe they have good what's it called? They have good strength, they have everything, but because of anxiety, you're going to see a lot of, they are very anxious because of their condition, because of their background. It could even be because of emotion. It could even be because of cognitions. Everything can be impacting that. Now they cannot step. What are you going to try? What are you going to do different with this patient? Pop those things in the chat box. Let's see. Yeah, use OS for transfer. I think, oh yeah, that's the previous one. Yeah. What are you going to do, physios? They can sit, they can stand, but they cannot step. Well, what else can we try with them? Maybe they can sit, they can stand with him. Yeah. What else do we do with them? So you're going to go there again, sit them, stand them, return them back to bed. You need to progress their rehab. So what are you going to do with them because of time, guys? Pop that in the chat box or open your mic, anyone. What are you going to do differently with this gentleman? Yeah. Okay. Yeah, rotunda, perfect, excellent, good stuff. Yeah. Yeah, with emphasis on close supervisions. Yeah, the patient can stand but cannot step. So using a walking frame, get beds to facilitate weight transfer and stepping. Yeah, good stuff. I love this one. Yeah, very good stuff. Yeah, walking frame. Yeah, rotunda. Yeah, good stuff. I'm really, really very impressed. Yeah, I'm very, very impressed, honestly. Yeah. So there are quite numbers of things we can, even beyond just ones I'm coming to discuss. Yeah, just like somebody mentioned gate bed. You can pop gate bed. You can write, oh yeah, it's anxiety that is the limiting factor. Oh yeah, I'm gonna support you. Yeah, if you do this, if I'm gonna use this gate bed. It could be that maybe it is one of you, it is just one physio that has been seen them before. You can double up on them. You can go into double up on them. I think, yeah, that's why I've come with my second colleague. If we are really working at it, we're going to see a lot of patients that because of anxiety cannot progress. You can see that's why we are coming in too. Yeah, it's going to help you from this side. I'm going to help you from this side. Give that reinforcement, that encouragement, that reassurance that they can do things, they can step, they can progress. Yeah, it could be that you just go there with rotunda, just pop your rotunda in front of them. Yeah, look at this. It's going to give you good support. So just stand. When you stand, just stand still. Then we're going to just turn you and you sit in the chair. That's it. Oh, and some of them will say, yeah, let's try it. It could be as simple as that. You have helped somebody. You have helped life. You have progressed somebody. Now, they did that today. They did that with you today. It could be next time when you go, they say, I transfer to chair today now. Tomorrow I can start. Let me try. Those kind of things. About those things. Even with that rotunda, you can even do some stepping practice. That one I showed, I have the first one that I showed the other time. Can do some stepping practice with rotunda. Can get them to do some marching on the spot. You can get them to do some lateral weight bearing. Because not being stepping could be maybe they are struggling to weight bear, or maybe they are struggling to load some certain parts of their limb, depending on your patient presentation. Reason clinical reason these things. If they are struggling to weight bear appropriately on one limb, or because of pain, because of anything, degenerations or anything, can get them to do some leaning side to side, get them to do some marching on the spot, distract them if it is cognition or something. Distractions, these are your physio stuff. In fact, in the next section, I'm going to be talking about some of these techniques. Distraction, grinding techniques, get their family to be around for you, encouragement, all these things. Yeah, good stuff. Rotunda later in bed. Yeah, good stuff. Thank you very much, guys. Let me see. Yeah, I just finished up these questions. Yeah. How will you approach and manage a non-weight bearing upper or lower limb? Let's say you've got somebody with non-weight bearing in the upper or lower limb now. They have been reducing mobility and they've been in bed for 2 days and they are fatigued. Like they are saying that I'm knackered. I'm very tired. And normally before they come to hospital, they are normally very independent. But now they are needing assistance of 2. let me simplify this thing. Your patient is needing assistance of 2. They have non-weight bearing in their upper limb now, and they've been in bed for a while. What are you going to be using for them? They are in bed. They are needing assistance of two physios, and maybe to roll in bed or to sit edge of bed, but they have not been out of bed. What do you want to try with them? What do you want to try with them? What do you want to try with them? And normally, by their background, they are very, very good, very active individual, very independent in all ADLs. So what do you want to try with them? Pop that in the chat box. Let's just finish this question and we'll end today. Yeah. What do you want to do with them, guys? Pop that in the chat box. Pop that in the chat box. Pop that in the chat box. Yeah. Yeah. So you can try, because of time, you can try some of those equipment that we have mentioned, non-weight bearing. If they cannot weight bear on one hand, they can use the other hand to pull up. It is one leg. They cannot weight bear fully on one leg, and they are anxious. They are anxious to use frame. Don't forget, with frame, you should not be pulling on frame. I have said that earlier. But with all of this equipment, you can pull up. That will further give you some upper limb support. And again, with physio supporting you with a stance of 2, you should be able to do with your own upper limb support as well. It's going to make life more easier for us. It's going to make life more easier for us. Think about that. I will just take the last one here. How will you select an appropriate equipment? Patient in med fit, they are unable to mobilize to toilet. They've got postural hypotensions, unable to tolerate brief period of standing. This is my long-term case presentations. Why equipment will you support them? Patient now, the doctor are saying they need to leave the hospital now. And now this patient, they cannot go to the toilet. And this patient are having postural hypotension. So do you just say, physios, go home, bye, come to our outpatient facility when you are ready? Wow. What have you done? What have you done, physio? What have you done? You've not supported this patient. Somebody is having postural hypotension. They cannot even stand. And now they cannot even go to the toilet. And this patient now, they are going home. Have you had that discussion with them around bedside equipment? Oh, like, can we get something like a commode if they need to use the toilet? Have you established that they can complete? Maybe they can still sit. If they can still sit up, or standing is their problem, do transfer, pivoting transfer, do whatever transfer you want to use with them, banana board transfer, low lateral transfer, all those things. Or even if they can't, even if the problem is they cannot mobilize, right? They cannot mobilize. Can we just teach them some pivot transfer to sit in the bedside equipment for them to do their toileting? Get the family to get them what's it called now? Bedside chair at home for them to be able to sit out in the chair. Because if they go home and they are always in bed for their postural hypotension, that is likely what is going to kill that patient. Going to develop complication. That patient referral that you've given them to them, they might likely unable to come to your facility. And if you are a physio that are going in to see them at home, if you are not doing some of these things, getting that patient to be able to do that sitting, to be able to intermittently practice that standing, they will develop secondary complications, and that will be the end of them. So let's think about these things. So guys, I'm going to stop here today. Unfortunately, I couldn't cover some other important aspects, but hopefully in our next sessions, we'll be able to cover all of these things. Thank you very much, and thank you for listening. So that's it for today. Thank you. The organizer, sir.
Good evening, sir. Thank you so much for today. Okay, so just like he said, we'll continue with subsequent sessions, and Dr. Idris is going to give us every other information that we'll be needing in the group chat. And I think that will be all for now. If there is any further information, we will be well informed on WhatsApp. So with that, we'll call it a night. Good night, everybody.